Chairman, I can just confirm we're live now.
Right, thank you. Morning, everybody. Today's meeting, I'm the chairman. I'm Councillor Leslie Greensmith. I'm the chairman of this topic group. I have an announcement that I have to read due to the COVID-19 attendance of this meeting. Due to the coronavirus pandemic, the council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the council's website for them to do so. Members of the topic group are asked to keep their microphones switched off until called to speak and switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. If you experience connection or other technical issues, it may help to switch your camera off. Cameras should be switched on if and when speaking at the meeting. To indicate a wish to speak, members should use the raise hand function. This should not be used by members of the public. Officers and speakers are also in attendance, but will keep their microphones and cameras switched off until they are called to speak. The programme is planned to provide a balance of presentation and questions. To facilitate this, please ensure that all questions and responses are succinct. At the end of the scrutiny, recommendations will be formulated. A short report will be produced of members' conclusions and recommendations. The implementation of the recommendations will be monitored by the Impact of Scrutiny Advisory Committee approximately 6 months after the report's publication. To assist members, the Scrutiny Officer will summarise the contributions and the conclusions reached by members after impact from witnesses during the programme. Breaks have been incorporated into the meeting as appropriate. Could I ask people to introduce themselves? I'm Leslie Greensmith, the chairman. I'm from Goffs Oak and Berry Green District. Tina?
Good morning, I'm Tina Howard, Hemel Hempstead South East.
Jonathan?
Yes, Councillor Jonathan Kay, Conservative Councillor for Ware South and a member of the Adult Care and Health panel.
Ron?
I'm sorry, I had me. Liberal Democrat, Ron Tyndall, Liberal Democrat County Councillor for Hemel Hempstead St Paul's.
Right. And have we got Margaret on yet or not?
No, Margaret hasn't joined us yet.
Okay. Right. Now, agenda item 1. Have we got any apologies? Do we have apologies from Margaret, or she?
We have no apologies from members, officers or witnesses, Leslie, so I'm assuming that Margaret will join us shortly.
Okay.
But
and also we have Richard Roberts with us. I don't know if you'd like to introduce yourself, Richard.
Why not? Richard Roberts, member from Kings Langley and chairman of the Health and Wellbeing Board and executive member for Adult Social Care Relationship with Health. Thank you, Chairman. Have a good day.
Thank you. Right. Now, I'd like to remind everyone present that scrutiny is a councillor-led activity. All questions will be raised by members. I will not allow cross-questioning by any witnesses. I expect all questions and responses to align with the key lines of inquiry on the scope. Natalie will remind us of them shortly. Please ensure that all questions and responses are succinct. The scrutiny officers will keep a list of members wishing to ask questions. I will endeavour to include all questions. However, I may move us on if time is pressing, and I will ensure that all members have an opportunity to raise questions. At the end of the scrutiny topic group, we will review the evidence presented and consider its recommendations. Recommendations will be formulated with a short report which will be produced. This will be published on the authority's website. The implementation of the recommendations will be monitored by the Impact of Scrutiny Advisory Committee approximately 6 months after the report's publication. To assist members, the scrutiny officer will summarise contributions and the conclusions reached by members after input from witnesses during the programme. Confidentiality. Scrutiny is held in public and any evidence provided will be available to the public. Issues of a confidential nature should be framed to protect a person's anonymity. Agenda item 2, work of the topic group. I would ask members to note item 2, the work of the OSC topic group. I will proceed on the basis that members have read all papers in the agenda pack. Head of Scrutiny, Natalie, will remind members of the group's remit. Natalie.
Thank you, Chair. This is just to ensure that members, but particularly our witnesses who perhaps haven't lived and breathed this quite as much as the rest of us, just a reminder of what the focus for today's scrutiny is. Obviously, this is an issue that's very close to a lot of people's hearts and has caused quite some anxiety within the community. So I think it's really appropriate that members have identified this as one of the priority scrutinies for them to undertake. So the objective is, though, to investigate how well COVID-19 was managed by care providers, and I think it's really important that the emphasis is on care providers and the care that was delivered in people's own homes or across other care settings. The lines of inquiry, you have 4 to run through today. You're looking particularly at the management of discharge from an acute setting, the testing regime of staff, the issues around PPE, and any financial support that was provided either by central government or the county council. Where your recommendations should be focused is to see how well measures taken by the county council and care providers did in fact safeguard residents in residential care or in their own homes. And as is often the case, there are constraints within this. This scrutiny is very much about what happened within the Hertfordshire context. Clearly, there will be some national implications that you'll need to consider because they informed the responses in Hertfordshire. But what you're looking at is what was the difference between the local response and how that ensured safety of the safeguarding of our vulnerable residents, and not about the validity of the guidance itself, which had been agreed at national level and clearly could not be changed by the local context. But you will hear from ACS officers and other witnesses about how that guidance was introduced into Hertfordshire and made meaningful for care providers, etc. If I may, Chair, can I just quickly comment on the programme?
Yes, of course.
Thank you. It's just to say that we've come up with a programme that covers the key lines of inquiry. What we've got is an overview from Chris at when this slot has finished, and then you get the user and carer perspective. I've been informed by Roma Mills from Carers in Herts and Jeff Brown, excuse me, from Healthwatch Hertfordshire, that they are planning to be available for most of the day. So if questions arise that you'd like to direct in their direction later in the programme, they will be available. I believe that Jeff will be absent for a short period of time, but otherwise they intend to remain for the duration. After lunch, I will provide a summary of the morning's scrutiny, and then Jackie Aubrey, the Interim Assistant Director for Resources and Planning, excuse me, will then pick up that slot about financial support. Chris Badger and Richard Roberts have got a scheduled meeting which they need to attend, so they will need to absent themselves at that point. So please, if there are any questions that are pertinent to them at that stage, please hold on to them. And that's all I wanted to say on that score, Chair. So back over to you.
Thank you. Right, the scrutiny of care delivery during COVID. This is a one-day scrutiny. Members will take all evidence from this scrutiny during the meeting. Whilst there's some flexibility built into the timing of the programme, it is crucial that we hear from all witnesses. Breaks have been built into the programme. I would like to welcome our witness who are assisting our work this morning. I would ask that you give a short introduction and your role in the scrutiny. Each presentation will last approximately 10 minutes and will be followed by questions from members. Chris Badger will provide us with an overview of services to adults in the care setting during COVID. Over to Chris, please.
So hi everyone, can everyone hear me okay? So I'm
Yes.
Chris Badger, I'm the Director of Adult Care Services at Hertfordshire County Council. I'll go through some slides just summarising the response and the support to care providers. What I'm going to do is I'm not going to go into too much detail, Leslie, because obviously you've got specific witnesses going on the particular themes that's set out in the question. So I'm just going to give a bit of an overview to set a bit of context and so forth. Okay, so if I just take us back to February, so actually, sorry, January last year. So over a year ago was when we first got indication that COVID-19 or coronavirus, as it was then called, was likely to come our way in some form. At that point, it looked inevitable that we would get some level of outbreak. Not yet clear how bad that would be, but we were planning on it being significantly disruptive. So from about January and February onwards, the planning really accelerated in terms of what we would need to do to respond to such a pandemic within Hertfordshire. A lot of that planning had been laid out already in national guidance around planning for the flu. So flu pandemic planning, which had always been a significant risk register. And I think through today, we'll find out which bits of that preparation around flu, both nationally and locally, were relevant to what we've then had to do, and which bits really flu planning wasn't really fit for purpose in terms of what we were doing. So just wanted to give you a bit of context that the planning for this started before the first case was arriving in Hertfordshire, which I think was the last week in February or the first week in March. That gives you a sense then that this has been something that we've been going at for about 14 to 15 months. And essentially as an adult care department, working very closely with our care providers, we've been working on a incident response resilience footing for that entire length of time. Before I get going on specifics around the response, I just wanted to give colleagues that don't know about how adult care works and how we work with providers a little bit of context about what that looks like. Is that okay, Leslie, just to give people a bit of background? So
yes, of course.
So broadly, adult care services, I don't need to tell you too much around this, you'll know, broadly support either people of a working age with a disability, whether it be a physical disability or a learning disability, or older people who've got social care needs. Now, broadly, as is the case with most of the country, support is either provided directly by the county council, so by county council employed staff. So we have a relatively small amount of county council employed staff that deliver care directly. So our day centres for people with a learning disability, some of our supported living units for people with a learning disability, and some older people's day centres are still provided by directly employed county council staff. So in a sense, we provide that care directly. But most of the care that is provided in Hertfordshire, social care that's provided in Hertfordshire through, for example, care homes or home care or personal assistance, is provided by contracted partners, so providers, care companies, charities, organisations that provide care and that we commission or contract with them to do that. Now, there's some individuals don't receive any support from ourselves financially, so what we would call self-funders, so they're in a sense sorting out their care themselves, and they secure that care from often the same providers. We don't necessarily have a contract with that provider because they may just deal with purely self-funded individuals, but they still have the responsibility to provide care to the standards laid out by, for example, the Care Quality Commission. What we found, of course, is that COVID doesn't respect any of those boundaries. So COVID cuts across all of those types of care. So when we talk about providers that we supported, and Sharon, who is on the call, will talk about this later, we're talking about both our services that we provide directly Secondly, those services that we commission and contract, and within that group, both services that are provided to people that we support through local authority funding and commission directly, and those services that are provided to people that are entirely self-funding, who we may not have anything to do with whatsoever, but still receive registered care services from care providers in Hertfordshire. So when we talk about providers, we mean the whole lot, Leslie, just to give you that context. So we can just go down to the next slide. So just a reminder, these are the 4 questions that are being posed: the management of discharge from acute setting to an individual's home or care setting, which we'll go through. The effectiveness of the testing regime of staff working in individual homes or care settings, so that's the testing for COVID-19, and the availability, use and distribution of PPE and training. PPE is personal protective equipment. Obviously a key plank of infection prevention control, which we'll talk about, and then the impact of any financial support provided by central government or Hertfordshire County Council on care providers. So they're the 4 questions that we're going to go through, and Leslie, you've laid those out already. So if I can just go on one. So here I wanted to just lay out the impact that COVID's had in terms of the scale of the impact, which obviously has been particularly tragic within social care for a number of reasons, which we'll talk about. So this is Office for National Statistics data. So this is nationally available data, and it talks about deaths in Hertfordshire care homes from April 2020, when they began collecting the data. Obviously, that's about 6 to 7 weeks into the pandemic back last year, up to the 19th of February, so pretty recent, and it's a rolling 7-day total of deaths in care homes related to COVID. So what you'll see there is 2 distinct waves. The first wave is when we got the initial outbreak, peaking just at the beginning there on about the 28th of April, and then it going down really as lockdown impacted. Relatively stable position all the way through the summer into early autumn. You'll see it begin to tick up in November and then go down again. You see that just between the 16th of November and the 16th of December there. Can you see that? Where that dropped off again, we think that was the impact of that lockdown that occurred in November, that you'll remember, the 1-month lockdown. And then what we saw very much early signs in late December, and then really taking off, was obviously a second wave of outbreaks in care homes. This is mirrored nationally with the overall outbreak pattern. Our hypothesis, and it's no more than that at the minute, but our hypothesis is that that wasn't because care providers or the county council took their eye off the ball in terms of COVID or in terms of infection prevention and control, but rather we were seeing the impact of the much more virulent and transmissible Kent variant, because clearly the epidemiology of the outbreak changed again in December. To test this, we've looked at this data for all other councils in the region, and they broadly follow the same pattern. In some areas, for example, further north in the region or more coastal areas, they saw less of an impact in April 2020 and more of an impact in 2021 because of the nature, I think, of how the outbreak started the first time round. So the first time round, it very much looked like it came from London and came out of London. And therefore, the national lockdown that was instigated in March probably caught COVID before it really reached the likes of Norfolk and Suffolk in quite the same way. So they've seen a worse outbreak this time than the first time round, whereas we've seen it peak at about 55 to 60% of the position it reached in the first outbreak. So these things are portrayed nationally. Even later data suggests that the number of infected residents, I'll talk to in a minute, has gone down really quickly. But underneath that, we're talking about all care settings, so home care, supported living and care homes, but care homes is the one where with the most data, and this is showed as an example to demonstrate the outbreak within Hertfordshire and the kind of pattern it took. So we can go down another slide. So this slide shows at the bottom, you've got every every week between the 17th of April to the 23rd of February. This is data that we collected locally in Hertfordshire, and this is number of residents that have been diagnosed. This includes all care settings, not just care homes, all settings. So it's just residents diagnosed, it should say. That's Hertfordshire residents rather than residents in care homes. Number of outbreaks that we've got is that purple line. So that's the number of settings with a outbreak, whether it be a care home or a care provider. And then the grey number is staffing. You'll see then, so this isn't deaths, this is number of people that have tested positive. Well, this will come up when we talk about testing, so I won't go into it too much. You'll see there that it looks like we only ever had 300 residents in that first wave tested and diagnosed with COVID, and that actually came significantly after we think that the number of deaths peaked in care homes. That's because testing availability only came online an awful lot later. So testing availability is now, fairly significant within the country. I think, we can do up to 700,000 tests a day. From the early part of the outbreak, that testing capacity was not available. So we'll never know what the prevalence of COVID in care settings was in that first wave, because we weren't clear who did or didn't have COVID at that point. So again, what you've seen here is a significant, very rapid spike. There's an anomalous bit of data there, which is why you see that spike, but I purposefully kept it in there so that the data's got integrity. I'm not fiddling with it, but essentially, if you forget that one little direct spike up, the overall pattern remains that we got to 800 staff with COVID in January. Partly that, of course, relates to much increased prevalence of testing and the testing regime for care home staff, which I think Tom's going to talk about later. But what you've also then seen is a very significant drop off as lockdown begins to hit in early February, and we hope the impact of the vaccine. So we're now at levels broadly where we were at the beginning of December. Now, and obviously we hope those trends continue to go down. But what you see there is very significant increase in the prevalence of COVID in care settings in the second wave beginning in December. Just gives you a pattern of the history of the outbreak, Leslie. So we can move on one. So I'm not going to go through the detail here because it's going to be covered in one of the sessions, but just to give you some of the highlights and some food for thought. One of the things you'll want to discuss, and we've mentioned in the report around discharge from acute settings into care settings, is what was the government policy? What was the government policy from NHS England around discharging people from the acute settings, and how did that change? How did we respond to that? The importance of testing, as I've mentioned, within discharge. So when did testing become available to the extent that we could tell whether people had COVID or not when they were being discharged from acute settings? How did so-called designated settings develop? So a designated setting, and we'll talk about this later, no doubt, is where a setting, particularly care homes, are designated to be able to accept people with a COVID positive diagnosis. And how can they be cared for within the designated settings so that they can see out their isolation period, so they're not infectious before they then go on either to, say, home or to another care home. Obviously, a policy brought in by government designed to protect care homes by having a few smaller number of designated homes that are signed off by the Care Quality Commission to accept people with a COVID diagnosis to try and then prevent COVID spreading in the wider care settings. I then want to, probably it'll come up, is to talk about, well, what does that second wave of COVID in care settings tell us? Because in the first wave, we know that the amount of testing that was available nationally was very low. So it was very difficult to tell who had COVID and who didn't. We know that the PPE availability came on stream and got better and better as the year progressed, but wasn't where we all wanted it to be in the first wave. And clearly, the discharge policy in the first wave was more permissive than it has later become. So all those things were changed and tightened up significantly. We then get to a second wave, and there's still significant outbreaks in care homes. So it begins to potentially change our understanding of how COVID was going to be likely entering in care homes, because We know a number of the routes that were perceived to have been the main cause of outbreaks in the first wave have actually changed, whether it be, for example, discharges from hospital without testing changed, the level of PPE changed and so forth. And it begins to then probably change our thinking, and I won't get to an answer, that's for you to come up with later, but it begins to probably change our thinking of how COVID was entering care homes. And then finally, and we'll allude to this in the session on discharges, recently published white paper on health and social care, and it includes a big section on discharge from acute hospitals and refers to that as discharge to assess. So that's really a policy or an approach of ensuring people don't stay in hospital any longer than they have to because of the inherent risks of people staying in hospital when they don't have to, but also the importance of people using hospital beds that need hospital type care, and looking at them undertaking more rehabilitation and assessment outside of the hospital in discharge settings, for example, care homes or even their own home, and that being a very significant policy shift based on some of the learning of COVID. So that will be referenced in our talk, and it just I put it in there as a reminder that out of all the work that's happened on COVID, a significant amount of it will lead to change in how we work across health and social care. So there's been good learning, good and bad, which will inform how we work in the future, and discharge and how we support people and assess them for their ongoing needs, and where that's done and how it's done will be a good example of that. We can just move on. So testing is then another question. I've talked a little bit about the increased availability of testing as we've gone on through the year. Testing on discharge will come up. That changed, again, linked to the availability of testing. And you'll see that as the policy developed on discharges to care settings, how that relied on testing and much more reliant on testing as we've gone on, because the availability of testing has increased so significantly. Talk then about when it comes to testing care homes around the initial view around how lateral flow testing, just as a reminder, is the testing that you can do yourself without a lab, so it gives you a quick result. Isn't as accurate, that is agreed. It's better at finding cases rather than ruling out whether you've got COVID or not, but is available much quicker and at a greater scale. How that was initially planned to work for visitors in care homes to facilitate visiting. As the second lockdown came in December, that policy was postponed, and instead those lateral flow tests were used to underpin a testing regime for staff in care homes, and you'll have seen that big increase in staff being tested positive, getting tested and testing positive for COVID in December in the graphs I just showed you. That's partly as a result of much greater testing and surveillance of care home staff, but also important to talk about the different testing regimes in, for example, home care, supported living for individuals with a learning disability in that kind of accommodation is a different form of testing than the testing in care homes, where there's perceived to have been an even greater risk. So those are the kind of things that will get explored in the testing section. If we move on. Got colleagues to talk about personal protective equipment. So we talked about two issues really. We'll pick up in on PPE. One is the amount of PPE that is available or was not available at different times in the last year. Some of the initial issues around PPE and how that was available to the care sector. Then the development of the so-called national portal, which is the national supply chain for securing personal protective equipment, which it has to be said has proved to be pretty effective in getting PPE out to people. But having PPE is one thing. Using it properly and training and being clear what needs to be used where is another. Sharon Davis will no doubt allude to that. I put in there for you to have a look later is a link in here to the infection prevention and control page of the Hertfordshire Care Providers Association. I had a look at that last night to just illustrate it. And there is reams and reams of information and guidance around PPE, because it's not as simple as, well, you've got PPE, just use it. How do you put it on? How do you take it off? What's the effect of PPE to use in different situations? what PPE is right for what service users, how do you dispose of it, all those issues. So colleagues for both Sharon on behalf of the care providers, but also talking about PPE within the council and testing within the council. We'll talk about the arrangements we put in place as a council with the Hertfordshire Care Providers Association and with NHS colleagues to support providers on the training, information, guidance and compliance with the usage of PPE to support care providers and what they were doing. So there's two elements to that, Leslie. It's not just having the kit, as it were, it's also about how it's used and what does that look like. It is fair to say that it is extremely likely that an enhanced level of PPE will be required for the foreseeable future. That's not going away anytime soon and will be something that we'll need to keep going. That has a cost implication, clearly, as well as a operational implication in terms of how people are using PPE and our growing understanding of how COVID is transmitted, and therefore what level of PPE is appropriate to manage that flow. If we just go on, more, brilliant. And finally, we've got a section that Jackie's going to lead on finances, namely what level of support that we've provided as a council and nationally through central government to care providers to meet the financial costs of responding to the pandemic. I won't go into too much detail here because Jackie will go into it here, but just to make a couple of points, some of this is payment for extra resources, PPE, staffing that was needed to respond to the pandemic, i.e. it's a resource intensive approach to care when you're having to think about social distancing, pay for PPE, have more staff, get more staff because more people are going to be off with COVID or self-isolating. That costs money. But also because of different patterns in terms of who were accessing care, higher mortality rates, providers were also faced with lower income levels in a lot of sectors, not all sectors, but let's take care homes, less income coming through, and that obviously clearly is likely to affect their viability. We did not want that issues around cash flow and sustainability financially to be impacting care providers in the midst of a pandemic. So that funding also includes funding for supporting providers with their overall financial sustainability and cash flow, so that we're trying to minimise disruption to the market. Jackie will talk about that. I'm going to say now, it's quite complicated because, and we struggle to get our heads around it because of the amount of different funding streams that have come through from government. So there's at least 4 or 5 different funding streams from government that have come down. Our job's been to kind of interpret that, working really closely with Sharon and the team at HCPA, interpret that, understand what it means, try and get that money as quickly as possible from us out directly to the care sector who needed it in as efficient way as possible, whilst meeting the requirements of the different grants that we've had from government. But there's also been money that as a county council we've committed to do that ourselves, especially early on in the pandemic before national money was forthcoming and throughout. With the objective being, and I've always been clear all the way through, that we need to be giving as much confidence to the care sector to be focusing on infection prevention and control, managing services that they keep continuing safely and sustainably, by giving them enough confidence that money and financial issues would be sorted out and they'd be supportive over the coming months, and all the way through trying to be clear that support would be lasting for at least another 6 months at any one time, so that there wasn't any kind of cliff edges of funding, if you know what I mean, coming out that would cause anxiety and so forth. So Jackie will talk you through that, and she's got a short diagram that you asked for, just laying out the different funding streams, Leslie, that I know you asked for in the briefing, so it'll lay that out hopefully really clearly. So that's just giving you a bit of an overview of the different elements here that you've wanted to talk about. I've tried not to answer the questions, but rather set the scene for some of the questions and themes that will no doubt come out, because we've got individual sessions on each one. But that hopefully gives you a bit of an overview and a bit of a warm up. Leslie, is that okay?
Lovely, thank you very much. I see Ron has got his hand up. Did you want to ask something?
If I may, I'd like to take you back to the start of your presentation when you talked about the flu plan that was already available. Did that flu plan have a section on discharge from hospital?
No, Ron, it didn't really. It didn't talk about discharge arrangements, because I think the flu plan really, so the overall our preparations for flu talked about the importance of rapid discharge, and so for any business continuity thinks about, you know, if you've got a rail crash or a plane crash, always talks about what you can do to secure safe discharge for people from hospital. So that's always part of the plan. What clearly was different with COVID and coronavirus was the virulence and transmissibility of it is clearly significantly higher. I don't know the exact figures, Ron, but the natural R rate, so the reproduction rate of a typical flu, I think is broadly 1.5 if it's left unchecked. Whereas I think the natural R rate for COVID is significantly higher. I don't know the exact number, Ron, but it's nearer to 3. So it's much more virulent. So again, flu probably didn't prepare us for the speed of which COVID would take off. Yeah. So in a sense, while bits of preparations for flu were helpful in terms of how you, for example, manage staff sickness, how you manage PPE, it wasn't really at the kind of scale and intensity that a virus as transmissible as COVID would lead you to plan for.
Thank you.
It didn't really have a clause which was with the intention of clearing the hospitals as the government direction was.
I'd have to go back to it. It talks about rapid discharge, Ron. All things on emergency continuity talk about that.
Just to follow up on that, under the paragraph 3.1.1 at 4B, it says during the period of the pandemic, a great deal has been learned of the discharging of people from hospital, and I just wonder, in the initial stages, did our discharge teams in the hospitals find a willing helpers in the care providers? I'm not talking about the NHS. Did the care providers cooperate completely with our care discharge teams in the hospitals in order to facilitate what was going on?
Yeah, on the whole, the relationship between the discharge teams and care providers on the whole is really good. I mean, there's thousands of discharges a year on, so you know there's sometimes going to be ones that don't go as smooth as you want, all those different views. But on the whole, those relationships have been positive, and they work on them. Yeah, they've always got ups and downs in terms of and different views on things, but on the whole, they're really positive. Again, mainly throughout the pandemic, I think there's been really close working between us and the providers and we've looked to work together in response to learning more about the pandemic, learning more about the virus, and responding to different national guidance. What we've tried to do, and again, you probably want to ask Sharon this from the Care Providers Association, is from the care providers perspective, is take what's come from national government and make it as clear as possible. You know, what does it mean? So if you've got a big policy document or a big bit of guidance, it means lots of different things and it impacts lots of people. What most people in the system want to know is, what does that mean for me in my service? So breaking it down that way, and on the whole, and we've got a record of this on the Hearts Care Providers Association hub, which we've done jointly with HCPA have led on. All our documents around the guidance and letters and attach them all there. And we've kept them all for record so that we can show what support was or wasn't given in terms of, you know, trying to make that guidance relevant for care providers in Hertfordshire.
Thank you very much, Chris. I'll step down, Leslie, for now, but I'd like to come back. I've got one other question which is different. If there's time, I'd like to come back later.
Next, we'll go to Margaret, please.
Thank you, Chair. And thank you, Chris, for very, very interesting presentation. I was going to say, you said there was that anomalous peak, I think, on Christmas Eve, wasn't it, for staff in your graph?
Yeah.
It's interesting.
Yeah.
I just wondered whether that was the lateral flow testing coming in and everybody, you know, it did actually cause a peak at that point.
Yeah, I think, but I don't think, because you look at the rest of the data, I think it was related, Margaret, to when the lateral flow testing came on board. I think it was, but it's just, yeah, as you say, it's a data anomaly. I don't think we saw that level there, and it came off it. But again, I'm just conscious not to tinker with graphs, if you know what I mean, Margaret.
Yeah, no, that's sort of my job to interpret graphs.
Yeah, exactly. Yeah, so I don't want to.
Actually, my question really was to do with GPs actually, and the joined up work with the NHS right at the beginning. And because I was involved in flu pandemic emergency planning and training, in the past, really over the last 10 years, we've done quite well at, so we thought, preparing for a flu pandemic. And then whether we'd overreacted, because GPs isolating, making sure that, if possible, people didn't come to the GP, was part of the flu preparation. But I did feel that GPs were really rather left out right at the beginning of the COVID pandemic. And particularly, I was really quite worried that the GPs themselves were not getting the same guidance, actually, because I did know 1 or 2 of the care home patients were diagnosed with pneumonia late, when actually it was COVID, and they died. And it was understandable, but it was very tragic. And so I was just going to say, what are lessons learnt in that sort of joined up activity? Obviously, at the moment, vaccination has been largely put under the NHS, but it's becoming a joined up project. But I did think there were lessons to be learnt right at the beginning about leaving out the GPs. And I wonder what your thoughts were on that, particularly when you have a named GP often who was the care home GP, and really involving them in the whole, in the process, actually, for care homes particularly.
Sure.
And I was particularly thinking about testing, and I know it was very difficult because the government just didn't invest enough at the beginning in testing.
Yeah, so I think all different parts of the system were on, have to learn about the virus as you were going on, so it became clearer some of the presenting symptoms and so forth, and different ways where it first became apparent. And clearly the first time it becomes apparent is more likely to be in the hospitals than it will be, because people who had it in the community may not have known they'd even got it at that stage. It would have been like a mild case of COVID, would have felt like a mild case of a common flu or cold. What we found, obviously, in Hertfordshire, I think was helpful, was that we've always had, not always, but I've had a named GP for nearly all the care homes, rather than each resident having a different GP depending on where they come from, which makes it difficult to manage. I won't answer too much on this because Sharon will want to answer on behalf of the care providers. I suspect the kind of coordination of care and support to care homes during that first wave was different care homes have had different experiences. I suspect it was very much based on the quality of their existing relationship with NHS and other colleagues. So it will have been no doubt mixed. But some really good examples of planning and involvement, and other areas where perhaps they wouldn't have felt as supported. Obviously, being clear that all parts of the system are trying to work within an infection control environment and trying their best not to spread things either for themselves or for others. So that puts a different gloss on how things need to work in terms of coordination. So I think it will have varied depending on specific care homes and the relationships they had and the arrangements that they had. Sharon I don't want to answer on behalf of the care homes about how well they felt that went. I think Sharon will have some good insight into what that felt like in Hertfordshire.
Could I just have one little supplementary, which is really to do with, we've had lessons learned, and I know we've got better, but just currently, are we going to cover later in the session anything about appropriate testing now, especially for people with dementia? And
and the testing colleagues will be there talking about. They'll talk about what arrangements we had, how that's developed. But I think it would be worth exploring what that looks like in the future too, because I don't think testing is going away anytime soon. So anything that we can do around improving the effectiveness of testing for all groups will be part of that discussion, Margaret.
I can park that for then, because I think that is definitely an issue for us for recommendations for the future and doing it better.
Yep.
Thank you.
Thank you. Right, John now.
Thanks very much. I remember at the time with PPE, the whole world was looking for PPE at the same time. And I'm just wondering, what was the system? Do you wait for the government? Do you wait for the NHS? Can you locally contact local companies, or the care homes contact local companies in order to try and get more PPE? And my other question was about designated settings that you referred to. Did you struggle to find enough designated settings within Hertfordshire?
Okay, thanks, Jonathan. I'll take those two in turn, and then again, I'll give a sort of fairly overview answer, and then there'll be some, no doubt, follow up with specifics when it comes to that item, Jonathan. But I'll get my perspective out there. So yes, on the PPE, the challenge changed. So first challenge was, understanding the virus and what PPE was required for what situation. What was deemed effective and what wasn't, and that's changed as we've learned more about the virus. Similarly, linked to that was, well, what's available for meeting that requirement for PPE. And clearly, as I've said, it's a much more virulent form of virus than we're used to, and that means the requirement for PPE is greater, and therefore you need more of it, Jonathan. So in the first months where it wasn't available, you were essentially doing everything you can tactically to secure PPE, both providers themselves to secure it, but also as a county council, we worked hard to try and find whatever route we could to get in extra PPE through purchasing off providers, but also obviously then there was the government stockpile of PPE that came down. That didn't get going for quite some time because there wasn't enough nationally, or it wasn't the correct PPE because we were dealing with something very different from flu. But we were doing everything we could to secure PPE on behalf of the care sector from probably March onwards. And as that's gone on, so that was a bigger part of our work in the first wave than it has been in the second wave. So in the first wave, PPE, securing PPE, getting PPE out, understanding about PPE was a bigger bit of work than it was in the second wave. So as the summer went on and the national supply chain became much more robust, I think it's fair to say, and others will talk about that, it became less of an issue in terms of us trying to source it. We still got centralised stocks and so forth, Jonathan. As you'd imagine, you'd want us to have a backfall for where people haven't ordered enough or run out at short notice. But actually, it's become much less of an issue for us in terms of our role as county council, because the supply chains are much more robust, and therefore our role is much lower. Does that make sense in terms of the PPE? So in terms of designated settings, I think your question was how hard were they to set up? So yes, difficult. Difficult for a number of reasons. Number one, clearly you've got to set them up in a way that by their definition is designed to prevent COVID from spreading into other care home residents. So you can't have a designated setting in the middle of a non-designated setting care home. It's got to be by definition somehow isolated. Clearly in an outsourced model of care providers, in a sense, no matter what you pay, aren't particularly incentivized to run a designated setting themselves because of the inherent risks. There's been some, and this is a national issue, been some issues around whether certain care providers could secure insurance for such arrangements, as well as really, well, what's also the appetite for doing that, because clearly, you're also putting staff at risk with COVID positive residents and so forth. So our response from about April, May had been, well, we think the best way of doing that would be to do that provision ourselves, and hence the development of the 2 designated settings at Nevitts and Fairways. So they were introduced as extra capacity likely to be used for COVID positive individuals, before the policy of designated settings came about. So it kind of predated that, but was essentially a reflection of that policy before it was a policy, if that makes sense. We were using that as so-called COVID hot pathway to secure people's discharge who were essentially recovered from COVID to the extent that they were going to recover, but still potentially infectious, i.e. within the 14 days post their first symptoms coming forward. And we used those from the end of the first wave all the way through the summer, took the decision not to close them after the first wave, but to have them ready to go if a second wave were to hit, which it did. And again, what they naturally became were our designated settings. So although we got some designated setting beds from another provider, about 9 nursing beds later on in the pandemic, primarily our designated setting capacity was our in-house capacity that we had set up in the first wave. And I think now, thankfully, did not close down because we had to prudently assume there would be a second wave. So all the way through this, Jonathan, our assumption will always be there will be another wave. Whether there will or there won't is kind of immaterial, but we must go on the prudent assumption that there will be another wave, do everything we can to play our part to stop that happening, whether it be through vaccination, whether it be through social distancing and adhering to rules and supporting and protecting people, but we must always plan for the worst. And that was a case in point where we did that. And again, we're now thinking through, well, what do we do around the designated settings in the future? I'm obviously particularly hesitant to step those facilities down completely because they take quite significant resource to step up. And what we do know from COVID is that when it gets going and is on the uptick, it goes very quickly. And the one thing you haven't got is an awful lot of time to set things up again. So it's easier to perhaps de-escalate them, but not turn them off completely so that you can reinitiate them quickly when you need to.
Okay, thank you.
Thank you. Tina, now, have you got a question?
Thank you, Chair. Can I stand you on the spot, Chris, and ask you a personal question? How well prepared do you think the authority was to affect this particular problem? And what would you put into your emergency plan if you were asked to do it now? And I've got a separate one, which I don't think we've quite answered. We're talking about designated settings, but how many beds are there in the care homes added to the designated settings of the 2 prime areas?
What I'll do on that one is I'll pass over to a colleague to just get the answer on that one for you too, in terms of the total numbers for you. I'll get the first one. I'll do that first question first, the one where you put me on the spot. Yeah, thanks for that, Tina. So it's how well were we prepared for COVID-19 as an authority? I'm going to focus on adult care because clearly COVID, impacts all corners of the local authority. Okay, so but in terms of adult care, how well prepared were we? So I think we're well prepared for responding to an incident. That our emergency planning, resilience arrangements, business continuity as a council were pretty well rehearsed. We've had a number of incidents in Hertfordshire over the years. We have a lot of incidents every single winter that we're rehearsed on. So we're pretty clear on roles and responsibilities and how we change and morph as an organisation, evolve as an organisation into incident response from business as usual. So that felt well. That felt like we were well prepared. For example, we knew what we would do around it if a lot of staff went off within the council, how we would manage that. As it happens, I think we were very well prepared about working differently. So, for example, we're on Microsoft Teams now. I think that we were already in adult care working much more flexibly going into the pandemic because of what we've done around offices, how we want to make people work flexibly. So it felt like that was a change that we could make when we were locked down. We could adapt pretty quickly to that, and that felt we were well prepared for. I think the local authorities' preparedness for a couple of the issues, and that then links to the care providers, which is what we're talking about today, around some of the things were areas where clearly we were dealing with something that we'd not dealt with before. So that we've dealt with flu. We deal with flu every winter, okay? So at different levels, we deal with flu every winter. We deal with norovirus every winter. We're used to, for example, a lot of care capacity being taken out because either staff are ill or there's an outbreak in a care home that's close to admission. So we're used to dealing with that. What clearly we weren't used to dealing with is the virulence of this virus, i.e. how quickly it could get transmitted. Had very little experience because we've never had to really of understanding what PPE was used for what elements, because it was, always learning all the time about what was needed. So that was not something that we'd really held significant central stocks of PPE. It was always through various plans through a national stockpile. So we had to learn as we went along a lot about PPE and about getting it out there. So that was new. We talked about the testing regime developing very much as it went forward. So for flu, I think the key thing on, for example, flu is most of the time, when someone's got flu, it's pretty clear. What we learned as we went through was one of the issues with COVID and transmissibility is, as it's called, asymptomatic transmission, which makes testing so much more important, i.e. where people have got COVID but don't know they've got COVID and maybe working in a care setting. That was something that we learned as we went through. We weren't prepared for. Asymptomatic transmission wasn't really understood until later on in the pandemic, and that's where the testing becomes more important. Is that clear to you why that's important in terms of asymptomatic? So I don't think testing as a country we had what we needed to, and that wasn't available until much later. So similarly, as a local authority, we didn't feel like we was prepared on that, or necessarily on no understanding of PPE. I think we adapted really quickly to get that. What I think we were prepared for, which has helped our overall response and helped us compared to some other places, was a really effective relationship with our care providers. So with care providers, you're dealing with hundreds and hundreds of different care providers. So you need a mechanism for communicating with them on a basis of trust and credibility. We've tried to maintain a really positive relationship with the care sector in Hertfordshire, not with every single care provider, Tina. Sometimes we have our run-ins, as you can imagine, but on the whole, that's good. Having a coordination route through the Hertfordshire Care Providers Association, which Sharon obviously runs and you'll talk about later, was vital. So that gave us a good ground and good preparation in being able to have a conversation with the sector really quickly. I think we did well in terms of getting ahead of the game in terms of financial support. So I think we were well prepared for that. We were definitely, as I say, well prepared for how to manage an incident. I think where we weren't as well prepared is for things that hit us from the virus that were unusual, which set it apart from other outbreaks. So it's not just a bad flu. It is a very different beast in terms of things like asymptomatic transmission, different infection periods, and just its overall virulence. And those elements were ones that we've had to react to as we've gone along to get our understanding and knowledge up.
Well, thank you very much for all that. Thank you.
Thank you very much, Chris. I think we'll move on now. Ron, you can ask your question possibly later on in the presentation, because otherwise we're going to run out of time. We're now going to go to hear the user and the carer voice. I'm pleased that Carers in Herts and Healthwatch Herts have agreed to assist us with our scrutiny. Each person will speak for about 10 minutes. After our witnesses have finished, I'll then open the questions to our members, and I'll invite each organisation to speak for 10 minutes, followed by the councillor questions. So, is it Roma first?
Yes, thank you, Chair.
Yeah.
Yes, Roma Mills. I'm a senior manager with Carers in Hertfordshire, which is an organisation that's been working with unpaid family carers for 25 years in this county. We provide a range of support services and activities. We also manage a small domiciliary home care service that offers sitting and carers breaks and a day service. Additionally, we have a team of 6 Admiral nurses. I think that's been very useful during this pandemic. I'm primarily going to reflect on the impact on the people we work with. We have over 30,000 carers registered with Carers in Hertfordshire, and staff and a team of 40 volunteers have been making daily telephone calls to check on people, to check on their well-being. So I'm really going to talk about the impact, but speak briefly to the key lines of inquiry. I think, as Chris has indicated, the year has changed so much. So what I would have been saying to you about March, April, May is not what I'd be saying in the autumn, because in March, April, May, issues like discharge from hospital for people with COVID or people who were unwell or people who'd been tested and we didn't yet know the results were really very difficult for families. And we had to intervene and contact the care leads at both Watford General and at the Lister to make sure that the families were being listened to when someone was being discharged, possibly with COVID, and no clear discharge planning that the family had been involved with. The testing regime came really quite late. So many families were very concerned about whether domiciliary care workers were being tested, what availability there was for them. So again, that came on quite late. And so the confidence at the beginning of this was really very, very damaged. The availability of PPE, very difficult for people who use direct payments to pay for their buddies, their personal assistants, their home care workers. They didn't seem to get into the loop initially of being included with the availability of PPE. Again, that has now changed. They are now in the loop. They are able to get PPE for their own staff. And latterly, we're now able to provide PPE to the family carers themselves when they need it. So there's been such a change really during the year. And in terms of financial support from the county, I know my colleagues would say that we have welcomed that. We have found the county highly responsive. Senior officers have been available when we've needed to speak to them. They've been willing to talk to the voluntary sector. They've been willing to hear what we could say. But I think the message I'm going to leave with you today, and I don't think it'll surprise you, is that despite the best efforts from adult care services, from the voluntary sector, from all partners, those carers with the heaviest caring role, with someone at home perhaps with severe learning disability, severe physical disability or dementia, the carers with the heaviest caring role have really been very negatively impacted during the last 12 months. Carers UK has published research, Caring Behind Closed Doors, to look at what happened in the early months, and then Caring Behind Closed Doors 6 months later. And what that shows is that individual family carers have taken on heavier caring roles. And we would certainly see that now, partly because day services closed down. I appreciate the County Council has maintained its own day service provision at a reduced rate, but practically all the other day services that people would have accessed just closed. And that might be one little local services provided by the local church, or county-wide services provided by Heartswise or Age UK, or small local ones like we provide as well. So the things that people use to get a bit of a break, to go and have some stimulation, to meet other people, to socialise, that just stopped. So people were at home 24 hours a day. And think of that, if you're the elderly spouse of someone in their 80s with dementia, it's 24 hours a day with that person. Now, coupled with that, people, of course, were very fearful about having home care workers in the home. They were very fearful about the spread of coronavirus. They read about the rising deaths, and so many paused their home care. Many were not willing to accept a sitting service. I mean, I spoke personally to carers and tried to persuade them to accept a sitting service because I could see the huge pressure they were under. But nonetheless, they weren't. And when they paused services, when they then went back some months later to ask them to be reintroduced, they discovered that the home care workers who had worked with their adult son, daughter, or elderly parent were no longer available. They'd been deployed. That, of course, we could anticipate, but if I can put you situations where you have someone with no speech, very limited communication, needs massive personal care help, it's so important that they do have familiar staff coming into them. So I think we saw that. Now, secondly, the other thing that was flagged up by Carers UK that again we see in Hertfordshire, the needs of the people who are being cared for have increased. They've increased because they haven't had the activities, the stimulation, the socialisation. They've been isolated and stuck at home. And that's been a real fear for families. We've seen that in the home, but we've also seen that in the care home sector and the supported living sector, because people have not been able to visit, they've not been able to engage. Husbands and wives who would take their partner out from the care home, someone with dementia, and have a bit of community activity, have not been able to do that throughout this entire time. The concern about people in supported living, particularly those very profoundly disabled people who live at a distance, the concern about that, with inevitably turnover of staff, the staff are unwell, has been very great. The next one, carers, most carers are telling us they've had no break at all. And what the research says is having a break is what makes a difference for people. Having a break is what gives that carer resilience. And I mean, some of our strongest carers who perhaps have found their resilience and their diversion in being very active on behalf of our care services or the Hertfordshire Partnership Trust have really struggled throughout this time, because the things they would do to keep themselves well and active, to help them manage their caring role, just aren't there. And also health impact. The health impact, I think over half the carers surveyed have said negative impact on their physical well-being, more than half negative impact on their emotional and emotional and mental well-being. What have been the particular challenges? Well, the whole issue of not being able to visit in the care homes, and you must have heard that from your own constituents, but there was nothing anyone could do about that. It was just a grief. And for those who were bereaved during the pandemic, when a husband or wife or parent died in the home, there's a particular lasting grief that we're really going to have to make sure there's sufficient capacity in the bereavement and counselling world to meet. As I said, services just closing. Now, some services really stepped up to the mark and provided online alternatives. And that was great for people who could engage with online alternatives. And some of them have been absolutely super. But of course, the most profoundly disabled are not able to engage. They don't have the capacity to engage in the online alternatives. So they are just left. What other things were there available? Well, we were all working very, very hard to do what we could to support those families. But in the end, the support we gave them was a mitigation. It was a chat on the telephone. It was an online session. And we have done online sessions during the entire pandemic, Christmas Day, Boxing Day and New Year's Day as well. So if people were on their own or felt an hour having a chat or doing a silly quiz with me would help them, we did it. But in the end, they were on their own, at home, isolated, managing great, big, caring roles. And I think what that leads me to question is the resilience of our system, because with the best will in the world, with finance available, we could not meet their needs because of what the pandemic meant. It meant you had to isolate. They were often caring for people who are very clinically vulnerable in the home. You had to isolate. You had no choice. You were anxious about home care. You were anxious about home care coming into your home, so you chose not to use it. Now, in the second wave, we are beginning to see people coming back to use sitting services and home care again, because they find now they have to, not because the fear's diminished, because they actually have to. I think we'll have to look at the resilience of the system and how we meet this, and I think we'll have to do that system-wide, working with all partners, because we're going to have to be imaginative and lateral to think about this going forward. Back in the summer, we flagged up what will happen if we have a second wave in the winter. It was one thing for families managing when there were light nights, when you could be out in the garden, when you could call over to your neighbour. It was a very different thing managing when there were dark nights and you felt that you closed your door at 4 o'clock and heard nothing and saw nothing. And we weren't really able to rise to offer anything different for that. Having said that, I would again close on a positive note. I think the working together with the voluntary sector and the statutory sector has been improved, has really worked well. There's a collaborative approach there. And I would commend senior officers at Adult Care Services who have made themselves regularly available throughout the year to speak to carers, to attend Q&A sessions. Most recently, we've had Q&A sessions around the introduction of vaccination for people with learning disabilities. We had a big Q&A session with Jim McManus in December. 70 carers attended, hearing about the vaccination programme. And all of that has been greatly appreciated. When push came to shove, our social model now is based on people living in their own homes, which means that people with very significant illness and disability are living at home, and the backstop for them is the family carer. Thank you, Madam Chairman.
Thank you very much. I think maybe we'll listen to Jeff next from Health Watch, and then we'll have questions for both afterwards, if that's all right with everybody. Could I invite Jeff to speak, please?
Thank you very much. I thought perhaps I'd better say a little bit about what Health Watch is, and then talk about a bit about what our role has been during the pandemic. I suppose Health Watch has three main roles, really. One is to hear the voices of service users and patients and their communities on all aspects of health and social care. And we convey these messages to commissioners and providers to help improve services. We have a programme of what is normally engagement with communities and research. During the early sort of days of COVID, we had a sort of shift in approach to getting messages out to people rather than hearing people's views. And I think, again, reflecting what's been said before, we were sort of fortunate to have contact with HCPA and also with our national body Health Watch England in terms of making some sense of all the policy and all the other documentation that was out there to get messages out to people. So there's a role there about hearing people's voice, and we from May onwards started to get people's perspectives, and I'll talk a bit about feedback that we got. We also hold the system to account from a service user patient perspective, and we had regular contact with adult care services during the period. And reiterating what Roma was saying, we had very positive conversations with Ian and then with Chris and with Tom Hennessy as well, in terms of understanding the challenges, being able to raise concerns that had been raised with us, and I think the ACS team were commendably sort of transparent and open about the challenges that they faced. And the other service that we provide is to have a signposting service for people who ring us, people who are using a service, a carer, perhaps a family member, and so on, where they talk about challenges that they're facing in terms of the services that they get, whether that's through adult care, a care home, or whether it's through health. And again, we keep sort of detailed logs of the concerns that were raised, and I'll talk a little bit about some of the examples there. So sort of more broadly, we had issues raised with us from a national perspective, and what was the Hertfordshire position on those things. We had feedback from people about where service had been very good or where it hadn't been good and needed addressing. And then we also had our surveys from May onwards, which looked at people's experience during the pandemic of healthcare, of their experiences for people who were shielding, and also of their experience of support from the voluntary sector and from adult care services. And again, I'll talk about one or two examples there. When things sort of first kicked off, the sort of calls that were coming in from communities were really about 2 or 3 areas. I think one was around sort of concerns about patient choice in the early days. So whereas before people could have chosen a care home, you know, if they were being discharged, so there was a bit of concern in the early days about, well, how was that going to work without that choice? I think that sort of shifted more into a concern that people might be being discharged into risky situations, and how would that work, and what safety measures were in place. And again, that was very much a national issue that was being conveyed to us. And I guess there's a sort of national drive to discharge people was also leading to all sorts to conversations at both a strategic level and very much an individual level. And so there was a lot of conversations about that. And again, I think, you know, looking back, we can sort of see with a bit of hindsight, you can see how things played out. But at the time, it all seemed, you know, changing and complex and hard to understand, really. Some of the sort of other issues that were raised with us at the time, one was a specific one around a care home that the residents nearly all suffer from dementia. When there'd been an outbreak of COVID at the home, someone died in hospital, a resident. 4 people were very ill and they were isolated, but nobody else was isolated, because there was a sort of balance. The care home were trying to not to frighten people, not to alarm people, but also not necessarily, in terms of the feedback we got, protect people in that situation. And perhaps that links to the point that was made about, you know, how we deal with residents who've got dementia, or patients who've got dementia, in a sort of situation where we're expecting behaviours to reflect, you know, a need for vaccination or a need for social distancing and so on. And I think that's been a challenge both within care services and more generally. We had another example that was reported to us where a care home had an individual person was nominated as the person who could visit, and this was during the summer. That person got very distressed and became unable to visit the care home. but the care home wasn't really flexible about somebody else becoming that nominated visitor. So, you know, those sort of very practical issues are ones which also sort of came our way. We also did get sort of positive messages around, in one case where a social worker was involved in sorting out a care home, and we got very sort of positive feedback around that. When we had our surveys, which we launched in May through to July, there were very positive messages from those surveys about the communication generally from adult care services and how people were informed about how things were working there. And we also had some positive messages where care homes had interpreted the guidance and had sent letters or other communication to families explaining what the situation was. But we also had messages in the surveys about how difficult people were finding it to sort of navigate their way through changes in the way that, you know, what they could do, how care homes operated, how support operated as well. So, you know, some positive messages, but also some understandable concerns there. And I suppose sort of in general terms, and again, echoing some of the points that Roma made, I think, what we've sort of found, I think, as an organisation during the last 6 or 9 months is a very positive relationship with the voluntary sector, the parts of the voluntary sector, the way that there's been flexibility from commissioners to encourage working in partnership, working together to deal with issues across the piece, and perhaps an encouragement of sort of creative solutions to deal with what obviously was a very exceptional circumstance. And I guess also to reiterate some of the other points that have been made, I mean, our concern, I think, going forward is that we think people are less well, whether they're you know, elderly people or people who've got long-term conditions or whatever. We know that there's been a decline in people's mental health during the pandemic. And so there's almost going to be a need for more support rather than less going forward from people. But we don't really know which parts of that support network are still going to be able to function in the way that they did before. You know, lots of positives to take about how things have been, how people have been supported despite all the challenges, but a sort of message, I think, that those support networks are going to be crucial. And finally, I suppose that the Chris mentioned about discharge to assess and how that works and so on, and the point in the white paper. So we'll be interested to hear some of the conversations about that when other witnesses speak later. Thank you.
Thank you very much. Now, Ron, you have a question?
Yeah, I'd like to spend a few moments talking about informal carers, family carers. It's a terrible way of describing people who do a fantastic job, but are crucial to avoid the whole of the care system falling over, as Roma and everybody in the business knows, and that without those informal carers, we would have been in real trouble. And I just wondered whether, Roma, you, in your discussions with the individual carers, there had been many instances of problems or relationships with the domiciliary care providers breaking down, getting back to the heart of what we're trying to do, which is looking at care provision. What did the relationships between the individual carers and the care providers stand up?
I think, as I said, I think the issue really was that the individual family carers paused a lot of their domiciliary care because of the fear of COVID coming into the home. And that was at a stage where people weren't, probably using PPE that much, and the news was continually reporting more and more deaths. So I think they paused it. So the outcome for some has been that when they went to try and re-establish it, the same care workers, and that is important to people, same care workers weren't available. I think there were also concerns about the appropriate use of PPE. I mean, Chris has referred to that, people wearing it or not wearing it properly, or wearing it outside the home and coming in. But I would have said the relationships were not affected badly, except in those contexts.
Thank you. So would you suggest that possibly one of the major markers that we've got to do for when we start discussing whatever, for the future plan, is that the support system around informal carers how we have to react to them quickly, and also their needs during the course of the COVID. Would you consider that? I think that's really the focus.
That's the key for me, because I don't think that the current system was able to respond to that.
Lovely. Okay.
I don't think it had the resources to do it.
Thanks very much. Cheers.
Thank you. Margaret now, please.
Thank you. Thank you, Chair. And thank you for both Roma and Jeff from Healthwatch. And actually very, very helpful to hear what it was like for people on the ground, I feel. I was going to ask Roma, I'm actually currently, you can't tell from my background, but I'm juggling looking after my mum at the moment. So I'm in exactly that position, that I'm a family carer. She's 93 with dementia. I had a rather awful experience in January because I did get COVID, very unfortunately, while I was caring for her. Kent variant, different symptoms. And the care agency that was helping my mum said, oh, it's too dangerous for us to come in if there is COVID in the house. And I then had no support at all for about 6 days while I had to wear triple PPE and look after my mum single-handedly. I just wondered if there was any, I hope Hertfordshire never had that, but it was a nightmare. Fortunately, another care agency that we phoned up then really understood the position and then did come and rescue me. So it wasn't my full 10 days of isolation. But I just wondered, you know, what private carers, how they had reacted, how much support. I mean, Chris Badger actually mentioned that they are trying to keep in touch with all carers, including private care homes and presumably private care agencies. It's much more difficult for accountability, though, if they don't work for Herts County Council. But it was very, very tricky. I just wondered whether she'd ever experienced that. And another, just the other question was, she mentioned the day services mainly shutting, and I have really noticed that actually in Hatfield. Very tragically, our Friendship House has shut because of COVID and financial problems, because their meals for people obviously couldn't continue, and we are trying to save Friendship House at the moment. But I was going to say that I really think that's something the councils, we should have really thought ahead to think, how do we support those day services? If the county council ones could continue, how could we support the ones that were being run by voluntary groups? Because I fear we have lost quite a few in the COVID pandemic.
Margaret, could I just say that some of that could be asked of HCPA later?
I just wanted to ask
at this point.
Okay, that might be helpful, but I was interested in Roma actually mentioning how that was a lifeline to give people a break, and they weren't getting a break, but in the future they may not get a break because they don't exist anymore.
Can I say briefly, Chair, in response to the first point, yes, I would say in the first 3 months of the pandemic, we did have situations where home care workers were not willing to go into the home. If there was a fear of COVID, and that was particularly difficult if someone was being discharged. I had one carer being discharged, having been tested for COVID and waiting for a result. His wife was very disabled. So, you know, for him to go home would have meant her support would have stopped. We really had to negotiate very strongly with the hospital to let him stay in the hospital, actually, because of that. He died, sadly, about a week later. In terms of day services, yes, they closed down. I mean, the advice, of course, from government was you couldn't meet indoors with more than so many people unless you were within very particular support groups, like support groups for people with drug and alcohol issues. I think most services are operating simply for older people or for carers. You know, the danger was that within that cohort are a lot of very vulnerable people. So we didn't open our small day service because of the fear of carers taking that back home. Thank you.
Thank you. I see Chris has his hand up as well. Would you like to come in?
Yeah, just to pick up on two of those points from Margaret and to build on what Roma said. Yeah, on the point around carers being reticent to come in, that was more prevalent early on. I mean, you know, there's and you know, you can understand why, in the sense of they were worried about contracting the virus. Totally understand that. It's absolutely by no means a criticism. As we went on, I think the care providers got an awful lot better at and had more of a clear availability and robust availability of PPE, which helped understanding about it, training around it, and things like that. Built confidence. Some of them created so-called barrier rounds, i.e., enhanced rounds for those with COVID or suspected of having COVID. Clearly, the testing regime helped that because you could direct where that resource was needed. And try and separate rounds with people with COVID from those without. Otherwise, there's a risk of spreading. So I think that situation changed. Your point about accountability is well made, Margaret. Clearly, we've got more sway over people where we have a contract with, because we've got a contract with them, and we've got then different levers that we can pull. Now, we don't try to go to a contract to have to influence or seek to change behaviours with a provider, because if you go into the contract, you probably failed in the relationship. That's a backstop rather than something you go to straight away. But there's clearly some providers in Hertfordshire we have very, very little to do with at all, but some of whom we've had more to do with during COVID in terms of what support we can provide and links through with HCPA too. But clearly how we influence providers does depend on the nature of that relationship, Margaret. You're absolutely right. Just on day centres, just picking up Roma's point, again, just to be clear, we've maintained quite significant financial support to all day opportunities that we've traditionally been supporting, so we've not withdrawn that support. So they shouldn't be closing if we previously been supporting them because of financial issues. But a number of them have felt reticent to open, both, as Roma said, because of the issues around how they could be COVID safe within indoor environments, so forth. But that's not also for the service users, but also potentially a number of volunteers or the staff that work in those areas are also, might have been shielding themselves or clinically extremely vulnerable. The kind of demographic of volunteers tends to be, on the whole, more clinically vulnerable than non-volunteers because of the nature of those people that aren't now working and so forth. So that's another reason. But to be clear, we have maintained financial support where we've done that in the past to those organisations and have worked with them to try and get them to open. More open in the second wave than the first wave, including our own services, but clearly it's a priority for us to get as many open as possible and do that in a safe way, building on the learning that we've all taken from the pandemic to date.
Thank you.
Thank you. We now have a question from Jonathan, please.
Yeah, it's really also to do with Romo, and I suppose in many of the problems that you've outlined very well, there isn't really an answer if you're talking about the middle of a serious pandemic, that carers and individuals will be negatively impacted, just like children are negatively impacted. They can't go to school or to their sports clubs. Here we're talking about maybe church groups or Age UK, as you referred to, Roma. The home care is paused, no breaks for the carers, emotional and physical well-being problems. I suppose the only help is that we have the vaccinations, the individuals are vaccinated, the carers can be vaccinated. One would think that the home care workers will be vaccinated too. So that's our only way out, isn't it? There isn't a solution to some of the queries that you raised.
I've certainly struggled to find a solution. I've been invited to put them forward frequently. What I would hope is we look at how we build people's confidence for the future. How do we build confidence that actually it will be safe to have support in your home? How do we build confidence that it would be safe if there is a day service available at a reduced level? And I do think we've got to focus on that, because whilst I hear what you say, if we really want people to live at home comfortably and safely, and we're thinking about, in this case, for over a year, we do need to make sure whoever is supporting them gets the support they need to do it well. You will otherwise see home situations breaking down. You get safeguarding issues arising. It won't be sustainable. So whilst I think it is extremely challenging, I think we have to find some routes into what could be done to make people more confident about receiving support, and how can staff be supported to be confident about going back into day service or similar type activities. How can they be enabled to? Thank you.
Thank you.
Thanks.
Ron, did you have anything else you wanted to ask John? You are finished. Yeah. Ron, if I have
Yes, I'm finished.
one quick one from you, and then we'll go into a break, if that's
I'm
all right.
okay, thanks. I'm okay, fine.
Okay. Well, we have a break now.
Could I just ask Roma one question, sorry, which is to do with what I asked a little bit earlier, which was to do with confidence about testing people with dementia with a PCR test, because one of the problems is that PCR test can get spoiled, and so then when you have a fear that somebody in the family got COVID, you want to test your elderly, well, this is exactly my mum, 93-year-old with dementia. Yes. Then the PCR test doesn't work.
We have a section on testing later on.
Yeah, but Roma won't be here then. I'm just interested in how many carers realise that the PCR test doesn't work for an at-home test with people with dementia at home. And so it's actually very dangerous, really, because you just don't know, have they got COVID, haven't they? I mean, in my case, I tried very, very hard because I had COVID not to pass it on. And my mum's still alive, and we're not sure whether she had COVID or not. She had a terrible chest infection, was bedbound for 3 weeks on oxygen, dexamethasone, and she's just recovering now. But it was very frightening because we were told, well, the PCR test is invalidated by saliva, and they usually can't help it but to put their mouth down on the test. And when you put it up their nose, they say that's not as accurate as doing it in the mouth. Sorry, Roma.
I will be staying for the rest of the day. I would say that probably not many carers are quite as well informed as you are about these things, Margaret. Having said that, the fact that people like Jim McManus were willing to come out and do an information centre session and willing to do it over and over again so people can put their questions, they can get good, informed responses, they can understand what works and what doesn't. And I think sharing of information, I cannot tell you how well appreciated that has been. Thank you.
I agree. Jim has been amazing. Jim has also done things for care homes to get elderly in, I think, to get, family visiting as well.
We've got a long agenda, Margaret, so I think we need to have a break now.
Thank you.
If it's all right with all of you, if we just have a 5-minute break, is that okay, Natalie?
If members can do what they need in 5 minutes, I'd go for 5 minutes.
Yes. All right. So if we come back at 22, that's all right. Thank you.
Sorry,
Leslie, I'm not sure that we're like the live stream hasn't come on. So
okay.
She's very keen, obviously, Helen, to hear what you've got to say.
Oh, okay. I can actually confirm that the live stream is on now.
Okay, thank you very much. We now go over to Helen, who will outline the hospital discharge process during COVID, and that will be followed by members' questions. Thank you, Helen.
Thank you, Chair. Hello, everybody. I'm Helen Manoff. I'm Interim Operations Director for Older People's Services and Adult Care Services. And I'm just going to comment a little bit on section 3 of your background paper, just to give a little bit more info on that one. So I thought it worth talking about how we organise hospital discharge in Hertfordshire. So we have teams that are based in each of the 3 main hospitals, which are used by Hertfordshire residents. So the Lister at Stevenage, Princess Alexandra in Harlow and Watford General. And as well as that, we have teams that are dotted around each of the big hospitals that surround Hertfordshire. So little teams in Addenbrooke's, for example, or Luton and Dunstable in Bedfordshire. And those teams get involved where people are due to be discharged from hospital, and typically they may already have a need for support from care and support services, from social care, or it looks like they may benefit from an assessment with a view perhaps to some short-term support or some longer-term support. So I guess by implication, there is an awful lot of discharges that pass through hospital where our integrated discharge teams aren't involved. So focusing really on those more complex people who need that support. And so what we had in place and what we still have in place during COVID is a policy of, particularly where people are COVID positive, that they need to be undertaking a 14-day period of isolation. So if someone is in hospital, they're now medically fit to be discharged, but they're still within 14 days of testing positive for COVID, then our options are to discharge those people to a variety of different routes, depending on what their needs are. So one of the routes would be into a community hospital bed, so a bed which would be managed by Hertfordshire Community Trust in the east, or by Central London Community Healthcare Trust in the west, where people could go, particularly where they perhaps had rehabilitation requirements. Alternatively, we have what are known as designated settings. So these are places where we've had an inspection from CQC and they've agreed that we can use those settings to support people who are COVID positive for the remainder of an isolation period. And so we have a number of those dotted around. We brought back on stream 2 former care homes at the start of the pandemic. Nevetts in Buntingford and Fairways in South Oxley. And we've used those homes throughout the pandemic, and we use those as designated settings for people to go to complete an isolation period. And that's where they have got what's termed residential care needs, so relatively low acuity in the great scheme of things. If people have higher levels of need, then we have some nursing home beds, which are in one of our private nursing homes in Hertfordshire, where we've organised that with the care provider. Again, they've been assessed by the CQC to meet the required standards for infection prevention and control. And if people have COVID, but they're actually in all other respects able to return home and manage at home, perhaps with some short or longer term domiciliary care and support, then we've got arrangements with our lead providers where specific staff are what they call cohorted to work purely with people with COVID. So they've organised their staff teams into a group of teams that will work with people with COVID and a group of people who will work with people who don't have COVID. And those staff teams don't cross over. So in that way, we make sure that infection prevention and control is safeguarded. And clearly, both of those staff teams, whether they're working with COVID people or non-COVID people, we're absolutely clear about the right levels of PPE that they must wear when they're working with those individuals. So in that sense, we feel we've got a strong framework that we've built upon during the pandemic. We're really clear about how we are managing that discharge process. My note goes on to talk about the discharge to assess model, and I only joined the session in the last half an hour or so, but I did hear that Jeff in his evidence talked about this model. So during the pandemic, right at the start, the government made significant changes to discharge models from hospital and introduced or extended what's known as discharge to assess. And in discharge to assess, instead of having an in-depth assessment for care and support while you're still in hospital, the first priority is to get you out of that hospital and into a setting where your needs can be met on the right basis. And it might be that you're discharged home, or it might be that you're discharged into a residential care setting. But the key point is that the assessment of someone's individual care and support needs takes place in that different environment from the immediate and sort of crisis time when you're in hospital. So generally there is a view that this model is a useful model because it stops people having to make key decisions about their future while they're perhaps still recovering from the impact of the illness that they've faced. So it's a model that we're seeing rolled out more and more across Hertfordshire. I think Chris may have mentioned in his introduction that it's talked about in the white paper that's come out recently, which discusses integration between health and social care. I think our challenge now is about how we build on this model and make sure that it's fit for purpose. It delivers the right outcomes for people in Hertfordshire. There's been a need to work at great pace with this. We haven't yet had chance to take stock and evaluate the impact of this model. I know that Health Watch, which is Jeff's sort of umbrella organisation, published a report back in the autumn which set out some of the challenges that it saw from interviewing a number of people, I think nationally, who'd been through discharge to assess processes. And so it's really important that we do that taking stock and that we understand what the impacts of this model are and how we can manage it going forward to make sure that people's outcomes and the right outcomes from those individuals are put at the front and centre of this approach. And some of you may have heard of our Connected Lives model, which is our care and support, care and assessment model in Hertfordshire, where we really try and work with people to prevent or enable them to reach their full potential for independent living. And that model needs to be at the heart of our discharge to assess process within Hertfordshire, and that's what we're working hard to develop. So in the final section of my little report, section 3 talks about future. The funding streams during this period have been very much, well, we've had a lot of government funding that's come in to fund the period of people's discharge and then placement in their setting. Those funding streams are going to come to an end at the end of March. If we want to carry on locally with how we've organised things thus far, we'll need to discuss with the CCGs about how we want to take that forward. We're working on that right now. I suppose that will continue to be an area of focus over the next few months. I'll leave it there, Chair, and try to answer the panel's questions.
Thank you very much. I think we've got a question from Ron.
Hello, Helen, and personally, thank you and to everybody else for what everybody's doing. With the various hospital teams in the different locations, were they able to communicate with each other and upwards and downwards and coordinate best practice with each other and sort of learning factors? And then did that also transmit to the care providers? And so there was a sort of free flow of information. And did that work quite well?
Yeah, I think obviously, I don't know if it's come up this morning, but there's been a need really to understand about COVID and how we best work with it and understand and build on the learning. And that's definitely been something that our teams have been well placed to do. Each of those teams, one on the east, one on the west, is led by a head of service. Those individuals are, senior managers in their own right, and they're really well plugged into both the adult social care world, but also into the hospital world. So they have excellent relationships with the chief operating officers in the hospitals. They're also well plugged into the sort of clinical world in terms of good links with microbiologists and clinical directors in that health world. So they're really able to sit at that fulcrum, if you like, of the health and social care world, bring those two things together and negotiate, I suppose, between both sides of the coin in terms of bringing a good synthesis of each perspective together. Those two individuals report to me. We're really well linked in with HCPA, so the learning that flows through. So a good example would be the guidance that came out at the end of December, where we started to work to a policy of 14-day isolation period from previously testing positive. I discussed that with HCPA and took some soundings from them on how that would be best promoted into the care provider market, for want of a better word. And myself and those two heads of service work closely with HCPA on developing that guidance, making sure it answered the concerns that care providers might have, making sure that we assured them of the support that we give for that new change, and we were able to implement that in a sort of holistic way, I suppose, that hopefully was well received in them or was understood in the market.
Thank you very much, Helen. Very quickly, looking forward and turning to your paragraph 3.3.1 on page 13 of the pack. And the government funding is supposed to end, well, actually the NHS funding is supposed to end at the end of this month. Given the success of how everybody's worked together, but also I'm concerned about whether or not with the new creation of the integrated care service across Hertfordshire and West Essex, that the NHS may appear to become dominant, when in actual fact we've done brilliant work. Our teams have done brilliant work in the hospitals, actually teaching them how to do it properly. And I just wondered whether what you see as the priorities in the next few months to actually ensure that as we continue to deal with the tail end of this pandemic or this third wave, how we cope with that.
Sorry, Ron.
That's right.
Yeah, I mean, it's been a fantastic collaboration is my response to that in general. I think we've not seen ourselves as a dominant or a subservient partner during this period, and it's been clear to me that in terms of the services that need to be provided for people when they leave hospital, the council has really been leading that conversation and convening, if you like, the group of partners that need to come together and organise those services in the right way. And that's not just a council responsibility to provide, say, the home care or the residential care. It's also, a health responsibility around rehabilitation beds or access to therapies, and all those sort of ancillary things that need to wrap around to make that discharge process as successful as it possibly can be. I'm not saying it's all perfect, but I certainly think that the council, particularly with Tom Hennessy, who chairs the out of hospital group, we've set up a really good forum to work cross Hertfordshire really around this issue, and both East and West, Herts Valleys and East and North have come together really in that group. We've also got HPFT there and the two community health trusts. And it's really driven, I think, brilliant conversations and has been really helpful in the response that we've managed to put forward. So I hope that answers your question.
It's very reassuring. Cheers. Thank you, Leslie.
Thank you. We now have a question from Duncan, please.
Yeah, I know at least 2 people in the last year who elderly, underlying problems, went into hospital, but not with COVID. After they've been in hospital for a week or so, they got COVID. You talked about COVID people and non-COVID people and sort of separating them. That's really a tough call, isn't it? I
mean that the hospitals have tried really hard to cohort their environments so that they are, you know, operating in hot and cold areas, if you like, as the jargon goes. It's not easy. It's a difficult challenge. That the infection is very, you know, pernicious, I suppose, in that regard. We are very clear about the need for a COVID negative test in order to discharge anyone back into a care home, and the need for a positive test. If something shows as positive, then, you know, that's a different route entirely that we pursue. So I think lots of learning. We've understood as we've gone through this pandemic how best to manage that. I think we really understand the challenge now, but it's not easy.
But that's not just the individual themselves, though, but it's the staff too, who, of course, you know, go home and perhaps, you know, catch COVID. It's easier now with the lateral flow tests and the amount of testing that can take place. But I would imagine, you know, 6-9 months ago, that must have been a lot harder.
Yeah, I mean, you know, an awful lot of learning and an awful lot of changes in practice that have needed to be understood and then rolled out as we've gone through the pandemic period. And I think, you know, with some of the structures that we've had in place, the outbreak cells, the linkages with HCPA, the mechanism for understanding what's going on and responding to that, and then sharing that learning across the system, I think we've got really good at that. But it's been, you know, it's been some really tough things to have to learn, I regret to say.
Thank you.
Thank you. Now we have a question from Margaret, please.
Thank you, Chair. Sorry, we muted. Okay. Helen, I'm not sure, are you the person who also is involved in the assessment of the patients when they get home, and what Roma mentioned about daycare and giving family carers a break when they're looking after, for instance, somebody with dementia or somebody needing a lot of care at home?
Yeah, I think the community teams tip. So the older people's services I'm talking about now is largely divided into teams that deal with people who are coming out of hospital, and teams that are working in the community to, for example, prevent someone going in, or to make sure if they don't need hospital at all and it's not on the radar or at all for them, but they need care and support, to organise that support for them. So I think typically, unless it's a case of someone coming out of hospital, if it was someone in the community whose care arrangements have broken down, we'd no doubt want them to have raised that concern with us, perhaps through our social care front door, and for that to have been dealt with in that community team. I know that the teams have done a lot of work to try and identify how vulnerable people were during the pandemic, and to you know, really target people who perhaps didn't have care and support networks around them. You know, proactive calls in a number of cases to check in with people and talk to them about their care and support needs, and how, if they weren't being met, how we could support with that.
I have been very, very concerned about how isolated people are, actually, and because of fear of COVID, they've been told to isolate, they've been told to shield, they are on their own at home, a lot of these elderly people. And I'm interested because I wasn't sure how many county council day centres had stayed open in COVID, because you really have to be a bit of an expert at social distancing and the COVID rules and hygiene, and thinking, how do we do it? And how do we, if they're used to going in a minibus, how do we do that, you know, to get them to the day centre? Could you just tell us a little bit about which places have done well at that, continuing? But I have experience in Hatfield, very sadly, with Friendship House, really, you know, being hit very, very badly. And in fact, I'll talk to you out. I was going to say, would you mind if I talk to you outside this session? Because we are trying to save Friendship House if we can for the future. But I'm just aware of that's not the only place that was really being hit by, not being able to reduce the services. And so more and more isolation, and what effect does that have on mental health?
Yeah. I mean, it's incredibly difficult, isn't it? And Roma touched a little bit on this in the presentation that she gave, and the risks of going to a day centre in the pandemic time are more significant, I think, well, it's a long process that plays out in different ways, but certainly at the height of the pandemic and at the height of the second wave, we were closing our day centres because the risks of people going to those centres, well, they were open, but, limited, I suppose, in terms of the capacity. So it's been a difficult balancing act where people haven't wanted to attend day service. So we've tried to keep as many of them open as been able to operate. Where people haven't wanted to attend, we've been reaching out proactively and checking in with people and seeing whether there's other forms of care and support that we can offer. For carers, again, really challenging, and I won't underplay how difficult that's been for people in those isolated environments. But we have put on more capacity to support carers with carers breaks and again, hopefully some of that reaching out and befriending work. Our older people's commission day centres, apart from one, have had to close. This is where they are typically part of an older people's care home, and we haven't been able to organise those centres in order to ensure required compliance with standards of infection prevention. That's because it's not possible to have isolated that day centre bit from the rest of the care home. So that's been too risky really for us to do anything with, although I think there is one older people's setting where there is that possibility to isolate, and so that's been able to continue. So it's been a challenge. I won't underplay how difficult that's been.
And have you?
Thank you. Can we try, Margaret, and stay on the key issues, because that's not really about discharge.
Well, it's the consequences of things shutting and what.
Yeah, because we've got quite a long agenda here. So
yes, but what effect that has had on patients, and then thinking what can we do about it to improve.
I mean, I suppose it might come up later on, but certainly for people with dementia, there's been a lot of work on an interim dementia strategy, supporting people around that risk of isolation. And I heard on the news today there was a discussion about how it's impacted people during the pandemic. And that might, I don't know whether that topic's on due to be covered, but certainly Adult Care and Health panel, that panel has reviewed that interim strategy and heard about the work that we're doing specifically in that area, but across the whole of the winter plan, really, the winter plan for adult social care, where we're trying to target key areas of risk.
All right, thank you very much.
But there is one other practical thing I was going to ask, which was to do with NHS continuing health care when somebody comes out of hospital, and when does that transition, and how do you assess if it goes to social service healthcare, and the integration, I guess, of the two, because often the skills needed, or the carers need to know some of the same needs of the patient, really.
And that's been a real positive, I think, of how teams have worked together very well during this period. And so with the new discharge guidance that government issued, certainly under Scheme 2, which is the one that we're currently working to, we have a 6-week period after discharge for someone's assessments to happen, and that needs to be both a CHC assessment, a continuing healthcare assessment, and also, if required, a care and support assessment. And so our teams have been working together around that. The NHS, the CCGs locally have given us some extra resource so that we can support the CHC decision-making process. And we're monitoring very carefully our progress through all the assessments that we have to do to sort of understand what people's long-term funding route will look like. So I think really good working is the bottom line on that one. Really good collaborative working.
Yeah.
Right. Thank you very much. Has anybody else got any questions for Helen? Because if not, we can. Oh, here we are, Tina. Tina.
Thank you, Chair. I'm just going back over something that you said about domiciliary carers having a rota for doing the COVID, or people that are out of hospital having had COVID, or the others. How secure are you in the fact that that has been going on? Only I'm hearing anecdotally that, because carers have left because they've been stressed out about their rotas, in that they're having to travel perhaps 5-6 miles between each person and then go back to the first one that they were at. I'm just wondering if you've got any feelings as to whether, you know, the policy of only having a set rota for people who, as I say, have come out of hospital or who have not had COVID is working.
Yeah, I mean, I think it's really important that we keep that, what they call cohorting in place. So only using one set of staff on people with COVID and the other set of staff on people who don't. So I think it's an important step in the arrangements that we need to make to make sure we've got good infection prevention arrangements. So I'm absolutely clear that it's the right thing to do. I haven't picked up that it's caused that sort of stress at an individual employee level. So I'm sad to hear about that, and I will certainly pick that up with our lead providers. I think what we want to see going forward is, you know, we need to be now morphing, hopefully, as the second wave passes through, and making sure we're putting the right sort of levels of COVID and non-COVID home care in place as we transition through the end of that second wave, and step down, if you like, the number of people that need to work on the COVID round than the non-COVID.
And can I just add there, anecdotally, I'm hearing that it took a long time before PPE was given to those care providers that are going into people's homes. And at one point, one particular carer was only giving one mask for the whole day for however many people they went into. And I'm not convinced, judging by the number of masks and gloves and pinafores that I see floating around, that they've actually understood what they're supposed to be doing. You know, going into a person's home with their gloves on when they've touched the gate, the doorpost and all the rest of it, and the key case, is not really secure. And I think that's why some of the residents have said that they don't want carers in their home.
I understand that concern. I think.
Can I just say, Tina, we're covering PPE this afternoon.
Oh, sorry. Yeah, all right, sorry.
That's okay.
It just fed on. Thank you.
And Ron, have you got something else you'd like to ask? Right, if everybody's asked everything they would like to ask of Helen, thank you very much.
Sorry, Leslie, I hadn't muted myself. Sorry, it was something based on what Helen had said.
Right.
To Tina, and it based on staff concerns. And I would suggest that as we come out of this, I think we really have got to concentrate completely on staffing concerns, on reactions from staffing, particularly the staff of care providers. There's also the potential of a Brexit fight in June, when we could end up, because of the idiot Brexit policy, we could end up losing quite a considerable amount of staff from the care home sector and care sector. So I do think, and the worries of care staff, I know of several care staff who have actually more or less given up the job because of the pressures they've been under. And it's worrying me that we need to really take hold of that coming out of the this third wave.
Yeah, I think that's really important for us, the morale across the care workforce. I know elected members have recently set a budget, and they've been very mindful of trying to improve paying conditions for those workers. I think we've got a great training offer that people can access if they're working in care via our HCPA partners. So, you know, welfare, morale, absolutely top of our agenda, and we're doing all we can, I think, to recruit and retain people in our services. Really good relationships with our care providers, and those sorts of concerns, they'd be quite happy to flag to us and for us to think about what we can do to respond. So always keen to be progressing that agenda.
Thanks very much, Leslie. Cheers. Thanks, Helen.
Margaret, have you got another question you need to ask?
It's a very quick question, yes. Actually, just following on from what Ron said, have you had increased numbers of carers recruited during COVID because of the need, and because of obviously losing staff, and because of many people losing their jobs and then becoming care workers? Have you actually had an increase? in carers?
I'd have to sort of go away and look at the numbers, but what I do know is in terms of the hours of domiciliary care that we're providing, comparing this December during 2020 with the previous December, we're putting on 6,000 more hours, additional hours of domiciliary care than we were this time last year. So my intuition is that underneath that there is, you know, the impact of that significant investment that elected members made in the care and support workforce last year, where there was a 15% pay rise for domiciliary care workers. We put them onto the equivalent of the London living wage, and we matched the differential up the pay grades, or elected members did. And I think that stood us in really good stead. I mean, it was totally unforeseen that we'd get COVID, but it stood us in really good stead in allowing us to have a really compelling hourly rate that we could pay to our care providers. And I suppose, as unfortunately in the wider economic recession or downturn that's associated with COVID and all of the economic pressures that that's brought to households, my thinking is there's probably been you know, an opportunity for us there to attract people who might have lost their job to come into care and have a new career working with us.
Thank you.
Okay, thank you.
I think there real are opportunities at the moment. So thank you.
Right, we could break for lunch now, and we will come back at 1 o'clock. So if you leave your computer on, just turn your camera and microphone off, please. Thank you.
Chairman, we are now live.
Great, thank you very much. Welcome back, everybody. Hope you had a good lunch and feel a bit rested now. The Head of Scrutiny, Natalie Rotherham, will give us a summary of this morning's scrutiny.
Thank you, Chair. I think first thing was to say is that I thought you got an awful lot of information out of the witnesses this morning, which is really helpful. I will do a summary of what you've heard. It just occurred to me, though, that maybe just to sort of capture, I thought a few areas which were beginning to emerge as across the piece were something around lessons learned. Everybody was using similar language to talk about the lessons that they'd learned during the time, and actually that was lessons learned in real time, so kind of the pressures that were on to deliver services, adapt and be quite agile around all of that. And then there seemed to be another pocket which fell into a broad heading of the future, and that was around relationships, and I will come back to these, resilience of the system, the services, individuals and providers, and planning activity. So just running into a quick drawing up of what you've heard so far, is that you got assurance that actually there was planning in place based on the flu epidemic planning, which gave a kind of useful structure for taking things forward. But the speed and the virulence of COVID was something that hadn't been experienced, and the flu plan didn't pick up for that. And you heard from Chris Badger around the scrutiny actually helping to identify where the plan needs to be modified to cope with future pandemics, hence a number of the areas that I started off by articulating. I thought there was quite a useful corrective around PPE, because it's not just having the PPE, it's knowing how to use it, how to put it on and how to remove it that make it effective or not. And I'm sure that will be touched on again this afternoon. And that it's likely that PPE is going to be a feature for services for the foreseeable future, which clearly has both cost implications, the interaction between staff and users and carers, and what levels are necessary to in order to perform the function. I'm sure that Jackie will reiterate Chris's statement that the finances are complicated. So we'll see how we survive Jackie's walk through the financing coming from central government and local government, see whether we're all got our heads together at the end of it. You heard that challenges changed. I think it's talking about lessons being learned in real time, that challenges had to be responded to really quickly against very stringent circumstances and time constraints, and some of those challenges were, as more was learned about COVID, adapting to what that new information was highlighting. There was a really interesting session around the designated settings and around how care homes could do that or not, but also the cost implications and risks for care homes in setting those up. And again, you might wish to ask Sharon Davis from Hearts Care Providers Association more about that during her session. And you heard from Chris that HCC took a decision to step into the designated settings to take on that risk and undertake to provide those beds and places, and that they were maintained for further surges as the first wave began to diminish. They didn't deactivate those two homes that had been brought online, because actually the cost of getting them accelerated step up is actually quite intensive. And you heard that from Chris that they're taking a prudent but worst case scenario towards planning in is actually keeping those homes in readiness should there be subsequent waves that require those beds to be taken up again. In response to a question around business continuity planning that touched on Chris's opening comments, his view was that the department and HCC as a whole were well prepared for responding to an incident. The authority is well versed in picking that up. And certain scenarios are pretty familiar anyway. Services around flu numbers rising during the winter, and the norovirus that breaks out every winter. But what wasn't prepared for and couldn't be because it was such an unknown was the virulence of COVID, PPE use, the need for testing, the speed of transmission from COVID, and all of that had to be learned about in real time. But what helped and underpinned it, and again worth exploring this afternoon with Sharon, is that what helped with all of that was the effective relationships with providers and the role that HCPA played in coordinating that. And also that, and this is something you can test out with Jackie shortly, is around the Chris's assertion that HCC ACS was financially ahead of the game, which I think would give some assurance to providers and to members about the security of services. You then moved on and heard from users and carers. Roma obviously was going to concentrate from Carers in Hearts on the impact on carers, and again she reiterated the speed with which things were changing very rapidly during this period, making it very difficult for Carers in Hearts and carers themselves to keep a handle on what was happening. What was concern was the increased burden of caring on family members due to the closure of family centres, compounded by a fear of not wanting paid carers to come into the home in case they brought COVID with them, so that people were not only isolating but isolated from services that would help them. One of the downsides of this was that where there'd been a familiar previous paid carer coming in to provide services, if that was paused, that person was likely to have been deployed, and when people wanted to reactivate the service, they could receive the service but didn't get that carer, and the distress that can cause for the cared for person. An assertion from both Carers in Hearts and Healthwatch that need is likely to have increased, that people are isolating or not, they're de-skilling, they're falling back, greater need for rehab, etc. So that's a kind of backlog problem that may surface. Roma talked about the importance of breaks for carers that actually helps give resilience to those individuals, but also, and again, Healthwatch talked about this, the health impact, both physically and emotionally, and on people's mental health in kind of an unrelenting pressure to provide care in pretty difficult circumstances. Roma concluded by listing a series of challenges, and again, some of these you'll revisit this afternoon. One was the difficulty of visiting a care home, bereavement where people had lost a loved one and not being able to follow the usual bereavement and grieving cycle that we have, and this may be at the moment a suppressed service issue which may surface as people come out of lockdown and COVID. The online activities have been an absolute boon. Being able to use virtual platforms has been great, but for some cohorts that's actually quite excluding, particularly people with dementia or learning disabilities. So it's not the solution. Roma talked about the resilience of the system, which I spoke about, and the sector worked well together, and a plea for that to continue. And she commended senior officers of the organisation, Chris and his team, and Public Health for all that they've done. You heard from Healthwatch, which made a move from doing surveys and research much more to messaging, making sure that messages were getting through and promoting the key guidance, etc., to ensure that everybody was getting a consistent message around that. And what they did do was any calls that they heard which raised concerns, they were able to field those directly to NHS or social care colleagues, and commended the transparency and openness of those partners in handling that. What you did hear was that one of the things that people were finding difficult, and I'm pretty sure that a lot of us here will recognise this, is the difficulty that individuals found navigating through COVID, its restrictions, and then guidance as it changed in response to the improved learning around COVID, and what was the most up-to-date information and how did people manage that. In response to questions, both organisations talked about managing through a pandemic, that there is no magic bullet, and a need to build confidence back around day services and people coming into the home, because if the majority of people are going to be supported at home, they need to have that support to enable them to have satisfactory lives. Then you heard from Helen Maynooth around the arrangements around discharge and discharge to assess, and you heard about the various routes that discharge operated depending whether people were COVID positive or not. And the challenge that Helen identified was building building a model that will deliver results in the future as we move forward, because it is likely that discharge to assess will be a primary route and therefore needs to be fit for purpose. So what Helen was describing was a need to take stock, analyse the results, review it, and then begin to develop an approach which will serve well, but also be linked back into the ACS model of connected lives. Clearly, funding is an issue, and Jackie again will come to that. The extra government money runs out or ends at the end of this month, and plans are already, or discussion is already taking place with health colleagues in terms of what services will be retained going forward, which will need funding from the health sector. In terms of the discharge teams, you got assurance from Helen that each team has a leader who is well plugged into both social care and health, with good links to the provider market, and discussions take place across each of those sectors and coming up with joint approaches and solutions. It seems as though messages that are being picked up through the Health Scrutiny Committee were reiterated here in terms of relations across the integrated care system. Helen described them as, fantastic collaboration, that ACS was neither dominant nor subservient. HCC has played a pivotal role in leading some of the conversations and seeing the actions that fall out of those. And also building, you heard that Future Plan will be looking to building capacity for carer breaks, which kind of links back to some of Roma's points. And you also heard that an interim dementia strategy is already being discussed at adult care and health panels. So the department have that in hand and are working on that. In terms of discharge to assess, where there may be not just social care needs, but continuing healthcare. You heard that the department has received extra resource from the clinical commissioning groups to support assessment for continuing healthcare, and to that resourcing to help understand what the individual's longer term care needs may be. And then just a couple of queries which kind of preempted this afternoon's discussions, and again encourage people, as the chair did, to hold on to those questions around staffing and recruitment, to test those out with Sharon from Hearts Care Providers, which was around maintaining staff morale, the importance of not just recruiting but retaining during a pandemic, and whether that's actually been more straightforward as people have been looking for alternative employment if they've been made unemployed, or have actually taken the time out to reassess what their career needs and future would be. So that is me, a quick whistle stop through a lot of information from this morning, and back to you, Leslie, as chair.
Thank you. I'd like to welcome our witnesses who this afternoon are assisting our work. I would ask you to give a short introduction of your role to the scrutiny. We will now hear from Adult Care Services on the key lines of inquiry, looking at financing, testing and PPE. So it's Chris or Jackie now.
Thank you, Chair. Yes, I'm Jackie Aubrey. I'm the Interim Assistant Director for Planning and Resources in Adult Care Services. I've been asked to talk to you this afternoon about the financial support available to care providers. I think if I can share a slide, if that's possible, that would help in terms of summary. If you could tell me when you can see that. It should be financial support to care providers.
Yes, we can see it.
Perfect. Okay. So just really thought it was worth summarising the support that's been put in place both from the government and from the Hertfordshire County Council, from ourselves, in terms of delivering to the care market. And there are various strands of funding that have come in with a number of constraints and rules around them, and our job has been to try and make sure that we get that we communicate with the whole of the care sector in terms of making sure that the funding gets out to support care providers as quickly as possible in a really clear and hopefully easy way. There've been two strands of the first two elements are infection control 1 and infection control 2. The rules around this funding have been constantly moving, and basically the difference between the two is that infection control 1 is the dates it covers. So infection control 1 was in place between May and September of 2020, and infection control 2 ran from the 1st of October and runs to the 31st of March. Basically, two lots of funding to the whole care market, slightly different constraints about the elements we had to hand out, but goes out to care homes on a per bed basis and community on a per client basis. Got most of that money out to care providers really quickly, and currently working our way through infection control 2 with 93% of the first allocation of infection control 2 has gone out to care homes, and 80% of the second strand. We're still working our way through that at the moment. So that's the first two elements. The third element on the slide is the HCC additional financial support, which is around support that we have put in place to care providers across the whole of the period of the pandemic. So it started off with an offer out to providers and started off covering additional staffing costs and PPE and additional costs generally that care providers were experiencing as a result of the pandemic. This was impacted and reduced in terms of our original estimates by infection control, which covers sort of staffing, the additional staffing costs associated with keeping people on certain shifts and not mixing staff between homes, but the additional costs, currently about 15.2 million, is our current estimate of what we think we'll have spent in the current year in supporting providers. That is on a claims basis, and that HCC additional financial support is to the care market that we commission with, and people that we actually commission care packages from. We have had a paper that's been to Cabinet that's agreed that provision extends into 2021 with agreement to the end of July and delegated authorisation to make a decision to extend that to September. And all the way through the sort of response to COVID, we've been really clear about trying to give care providers some assurance and some confidence about the coverage that we were giving them for their additional costs that they're experiencing. And so we've got £9 million set aside from the current underspend that we're carrying forward into, the £9 million, is against the COVID grant that HCC have secured from the government for next year. So there's a £21 million grant for HCC, and that £9 million has been badged against that grant, and that's our estimate to take us through to September. More recently, we've had the Rapid Testing Fund, which is about supporting the costs, the additional staffing costs and the additional logistical costs of helping care providers to support their testing regimes, and that's about additional staff time and can be about some of the costs of actually setting up a testing zone within providers, and that again is based on a per bed and per client basis, and that is £3.297 million out to providers. And currently 81% of care homes have claimed that, and that's to the whole market. And then very recently, the Workforce Capacity Fund, which is 2.067 million, is about increasing the staff hours that are available to care providers, and so that's about an initiative to help care providers fund additional recruitment campaigns or additional hours, so making available funds to support perhaps taking part-time workers for additional hours or paying overtime. And then the HCC providers at risk, we've had a scheme which has been in place for providers to be able to come and ask for financial support. It's been around in the current year. We have a set of criteria against which any claims are considered, and we have set aside a carry forward amount of from the ACS current underspend of 5.1 million into next year to be available to support providers next year. So in total this year, the support that's gone out to the market is just over 45 million pounds, and we've set aside at the moment 14.1 million pounds. But I think it's safe to say that next year is going to be really uncertain. I'm sure you've probably already heard that COVID is no respecter of financial years, and the impact on the care market, we're keeping really close watch on and making sure that we are able to support the care market. Thank you, Chairman. Oh, come down.
Thank you. Anybody got any questions? Ron.
Yeah, hi Leslie. I couldn't disappoint you. Jackie, the government have stopped the funding of the 6 weeks assessment from the end of this month. Have we got something already prepared to put in its place, or are we discussing how that will affect the care homes, particularly as I've just saw in the lunch break an announcement that HC1, one of the biggest providers in the country, are actually closing down 52 of their homes. So they're going to go on to other business, residential homes. So it's a question of trying to build some sustainability into the care home estate, is it not?
It is, absolutely. Yeah, I mean, at the moment we're in discussions with Health about the position post-March, post the end of March, and looking very carefully about what we've got in place and we're funding within the market, and then how we fund that together as a system going forward. So we're in negotiations at the moment about that funding. It's never certain as to whether the health funding will continue. We get quite late notice of funding, but we're going forward on the basis that funding doesn't continue, and working with our health colleagues to put in a model of sustainable funding to the market. We are really aware of the impact this has had on care providers, and have, I think, given a really clear indication of what support's available in terms of the additional support, and been constantly trying to make sure that we're having an open dialogue with care providers to make sure that those in difficulty that we support, particularly, but generally across the market, are really clear about where they can come to for assistance with that. In terms of HC1, I thought that they were selling their homes in terms of them themselves getting out of part of their market. But absolutely really keen that key parts of the market, you know, that we're there to support as appropriate.
Lovely. Can I just follow on by saying, and I realise you may not have had time to do this with all the other things that are going on at the moment, but has anybody attempted to break down the care market sector in terms of whether or not we've got sort of providers that just have 1 or 2 homes, with providers that perhaps work in one locality, to providers that are county or national? And from that, can you look at any trend for sustainability? You know, which model is better, the smaller company or the larger company? That sort of thing, in order to try and advise us on the future, as it were.
Yeah, I mean, the commissioners and we as a department are looking at the care market generally, and it's been very clear that some models of delivery are much more sustainable than others, and are much more, some are particularly at risk. And it's particularly about the model that's in place for the management arrangements tends to be really key. So small providers are, in this kind of environment, I find it difficult because they don't have the sustainability of being able to call on a number of staff. So the smaller providers tend to be in a more tricky situation, but equally it can be slightly larger providers that don't have the strength and depth of management. So it's really key that what's been really clear is the sort of the role of registered managers, and having a backup when particularly when whole staff groups have gone down. That's particularly key, and we're doing a piece of work now looking at those providers that have got key risk elements that we think we need to keep an eye on and help them to work through, and to make them more sustainable in a management arrangement as well as financial. So it's a sort of organisation sustainability and a financial sustainability is what we're looking at, and we're doing that at the moment, that work.
On a personal note, I'd be interested in a copy of the sustainability report when it's ready, if it's going to cabinet panel or not, just to you know, bring myself up to date. Thank you very much. Yeah. Cheers. Thank you, Leslie.
Thanks.
Thank you. Now we have a question from Margaret, please.
Thank you, Chair. I possibly should have asked this earlier. But I don't know the answer to this. In COVID, has council supported hospices and end of life care, which is more than just healthcare? And I'm saying this because I was quite worried. I saw, I think it was 2 months ago, might have been a month ago. I was trying to keep my eye on, you know, current awareness and current affairs, but Isabel Hospice had to shut because of lack of staffing and capacity, and I just wondered whether, I was a bit worried actually about that, and thought, what is the joined up health and social care for hospice and end of life care? And I'm sorry, this is a financial question really, because I'm saying, did we support them financially at all? But yeah, financially the support came through the through health. So in terms of the financial support was through the health route, Margaret, and we had questions from hospices and we're directing them towards the health provision. So in answer to your question, no, we didn't support hospices through these routes of these funding. I just wonder if that's a development area for the future, really, as we are trying to integrate our services, because it isn't all health, it's counselling and bereavement counselling, and you know, there are, I was just really upset, I suppose, that Isabel Hospice did actually have to shut just at the time when people really needed them in COVID. Thank you for telling me. Thanks.
Jonathan now, please.
Yeah, just a quick one, Jackie. In terms of the money you get from central government, is that based on population of Hertfordshire, or is it based on a proportion of older people we have in Hertfordshire?
Right, so these particular funding streams are based on the number of care beds we have registered with the CQC and the number of people that we are supporting through home care within Hertfordshire. So not necessarily us, but the whole market. So most of these funding streams are to the whole market and are based on the number of registered CQC registered beds in Hertfordshire and the number of home care people we're supporting with home care. Well, not we, but Hertfordshire generally is supporting through home care.
Okay, thank you.
I've got another one.
Did you have another question, Ron? Or is it a legacy hand? No?
No, sorry, Leslie. No, that's a legacy hand. I'll take it down. Sorry.
That's great. Okay. Now we'll go on to the care staff, talking about the COVID testing regime and PPE. I believe it's Tom.
Can I just ask something else before we move off finance? Just
if it's quick, because we've got quite a big agenda.
In paying for PPE as part of our costings, did we ever kite mark the PPE to say which ones we were paying for and which ones we weren't, or how the care homes had to comply with a certain kite mark of PPE?
The PPE actually comes now through the PPE portal, so supplied by government. So it actually comes that route. So care providers that are registered claim the PPE that way. So in terms of the funding, most of it actually is provided by the government portal. And I don't know if Tom seems to have disappeared off the call. I was going to say it because Tom would know more about the PPE and the in terms of the actual provision of it. I can't see that he's on the call anymore. So
yes, I can see Tom is here, and
right, Tom. I don't know if you
know about hospices as well.
Well, in terms of the PPE, I think that's going to get picked up by Tim Parlow, who follows on the next section. So I think all questions Tim can gradually pick up. But if I may, Chair, I wouldn't mind just picking up on the point around hospices. Because I think Margaret's absolutely right in flagging hospices. They are absolutely critical and important, not only from a health perspective, but from a social care perspective. And they do kind of bridge both those service areas. And they've been critically important to us in terms of how we care for people who may have to go in a hospice because of COVID or have got COVID whilst suffering from a long-term illness. And they've been, in terms of that offer and their expertise in end-of-life care, absolutely important. The issue for hospices, it's really difficult for them because they're neither seen as social care or health. They are a charity, but we've collectively in Hertfordshire, particularly through the clinical commissioning groups, have tried very much to, they're included in all of our discussions and our working groups, but we've tried to move money into hospices where we can, but it's been very, very difficult. And also some hospices at the start, or during the second wave, were a bit concerned about taking people with COVID, particularly if they've got, given the people that they care for, adding COVID to that mix is going to very, very swiftly impact on their well-being. So it's been very, very difficult. But their expertise in helping us and guiding us to how to cope with people who are unlikely to recover as a result has been critical. I think it would be useful to get their voice as part of any future discussion. They're very articulate. They're very strong in getting their voice across. But I do think that maybe they haven't been factored into in terms of the funding rationale very clearly through health and very clearly through social care. It's the right thing to do. But I think they do need more specific attention going forward. And that's something we'll probably want to include in future discussions.
I totally agree. I really like that to be one of our recommendations, because I wrote the end of life care report for the CQC about 8 years ago, and I'm very well aware that you know, the NHS basically gets away with an amazing service funded entirely by charity for end of life care, both for Macmillan nurses and for Marie Curie nurses and for hospices. But now in COVID, as you say, they are real experts, but they do deserve funding. They've been inundated. And as I said, I was a bit shocked to see Isabel Hospice actually shut when we really needed them most. But you can see why, because they're falling between two stools, and charity can't respond as, you know, they don't get the government umph normally, a boost. And so I do feel that's a whole area that we should comment on now to be able to do better in the future and to help them.
I totally agree, and for fear of stretching my remit here, I think the similar attention also for carers, the contribution that carers, largely unpaid, make to our economy, and particularly in response to looking after our most vulnerable, absolutely needs more attention.
Thank you, Tom. I agree. Thank you, Leslie.
Thank you. Right, if there's no other questions, is it Tim that's going to come in next, I believe?
Well, I think this section is us looking at testing for carers and also PPE. So I'm entirely relaxed if Mr. Barlow would like to go first.
Yeah, likewise, Tom. Okay. I'm more than happy to. Good afternoon, everyone. Just by way of introduction, I'm Tim Barlow. I'm the head of Integrated Community Support Commissioning for older people. And for the purposes of today, I'm here to talk to you about PPE, which my role has been primarily through the work we've put in place with Hearts Care Providers Association and the Provider Hub, but also working with colleagues on the Local Resilience Forum and the PPE Cell, which was founded way back. Seems way back anyway, sort of this time last year. I think in terms of summarising the kind of key points from the stuff that we've already put in the report, and you'll be hopefully relieved to know that I don't intend to go through all the figures that have been provided unless there are specific questions. But I think the response around PPE focused on three key things, really. Firstly, the dissemination, collation of guidance and advice and training to our care providers. Secondly, around distribution and access routes. And I'll talk a bit more about how that almost was split into two periods, sort of pre the national portal and post the national portal. And then third and finally, and perhaps most importantly, the role that we've played in going back to the advice and guidance, but proactively assisting providers through the outbreak cell, through the monitoring and the work, the contract management work that our commissioners carry out to ensure that guidance is being adhered to and that training is in place and that providers are fully supported in doing the right thing in terms of that guidance. So just going back to that advice and guidance, really, I suppose I was reflecting on this and thinking the interesting thing is that we during the course of this, and other witnesses have talked about this morning, it's a huge learning curve for people. So when I first got involved in conversations about PPE, the very first thing that we were talking about was hand sanitizer and the advice that washing your hands thoroughly for 20 seconds was absolutely the thing to do to prevent the spread of infection. And you know, that during the course of the last year, morphed from, yes, that's still really good advice, but then the additional layers that came on top of that. So, you know, initially we were saying to providers, actually, we're not sure about the efficacy of face masks. That's still being debated. The scientists are still looking at it. But the one thing that we do know is that you need to kind of wash your hands thoroughly. Through that whole period of time where we then it became much clearer that face masks were the right thing, that aprons, that gloves, and all the other kind of elements of PPE that got introduced. And just sort of reflecting on it from the point of view of a provider, a lot of our providers were dealing, well, all of our providers were dealing with something that they had never dealt with before, but that affects different bits of the care economy in different ways. So if you think about residential homes, actually their kind of practice and experience of infection control actually has quite a strong basis. People have already talked during the evidence you've heard today about flu outbreaks, but also picked up on things like norovirus. So in care homes, there is a kind of underlying level of expertise of how to deal with and minimise spreads of infections. For domiciliary care providers, whilst they will have heard of those things and dealt with those things, actually they will never have been in a position where they were particularly expected to be adept at the kind of use of personal protective equipment. It wasn't necessarily something that they were dealing with. So that advice and guidance was really, really key in terms of reassuring providers and ensuring that the standard of care and infection control was maintained. In order to do that, we relied very heavily on our standing up of the provider hub, which I'm sure Sharon from HCPA will probably be talking to you a little bit more about, so I won't major on that. But having that one point of contact that providers could, they could come onto the website and find all the latest guidance. Didn't matter whether it was issued at 8 p.m. the previous evening, you know, by the following morning it would be up, it would be clearly summarised, and the relevance to each different type of care setting would have been highlighted, because that's the other thing, is that those documents necessarily contain an awful lot of detail. They're huge, and actually when you're under pressure as a care provider, you want to get to the bit that's relevant to you. So we did a lot of work in kind of summarising and pulling out the key points. That was supported with training, with webinars, with some face-to-face training, and with colleagues from infection control, nursing in the NHS, and our public health colleagues actually going out to settings to advise. As I say, even simple things like, you know, it seems the most simple thing in the world that you would say, well, these are the items of equipment that you have to use in order to prevent the spread of infection. But actually, how you put those items, how you kind of put them on, how you take them off, how you dispose of them safely, all of that was new to a lot of the workforce. So really, really important that we did that. And then the other bit that I wanted to talk about was around the access to equipment. We know that back this time last year, things were very precarious in terms of supplies of equipment, and we know that there were lots of providers, lots of suppliers of equipment, some cynical and some thankfully well-meaning, who stepped in and offered all sorts of things. So giving that guidance of what was the right equipment. And just picking up on one of the questions earlier around the kite marking, one of the elements of that actually was around the different European and British standards information that was required. So making sure that the equipment that was being purchased actually met the levels of certification that were required. And what we did was we encouraged providers to source their own equipment. Many of them, I've previously mentioned, you know, care homes already had some supplies of PPE because of dealing with things like flu and norovirus, but there was new equipment that they hadn't used before. We were asking them to use their own suppliers. Herts County Council, working with our contract supplies department and our equipment service, also very rapidly mobilised to ascertain whether or not there was a stock available. We also called on the pandemic stockpile, I think that it was being referred to at the time. Secured those supplies and kept those centrally, so that where providers were unable to access information, beg your pardon, equipment, we were able to supply it to them. And then once the government portal came about, which was in about May last year, the role slightly changed in as much as it was supporting providers to register onto that portal, and then using the information that was given to us from central government about the portal, going back and just checking that all of the care providers in Hertfordshire had registered for it and that they were ordering that equipment via that route. The things that I've talked about aren't necessarily sequential, so the emergency supply of equipment through Herts Equipment Service, for example, continued even post the standing up of the government portal, and that was because sometimes the government portal was unable to supply the right amount of equipment or sufficient equipment. So we've kept that up and running throughout. And I think in the more detailed stuff that I've put into the report, you can see that during the course of things to date, something like 1.5 million items of equipment were delivered via that Herts Equipment Service route. And that providers in Hertfordshire have so far secured something like 7 million pieces of equipment through the national portal. And then the final thing that I just wanted to highlight was the support to informal carers and also to personal assistants. One of the perhaps points of learning around things like the national portal were that a lot of the access in the early days, and the same would go for testing actually, was reliant on CQC registration. And so our independent providers had access, but if you were a private individual actually employed by a resident in Hertfordshire as a personal assistant, you didn't have that same kind of equality of access. And so that was something that the Local Resilience Forum and Herts Equipment Service stepped into, and I'm pleased to say, and I think Roma mentioned it earlier, that we're now at a point where actually that supply route is fairly robust. There are stocks available, and I think both carers in Herts and our own warehouse at Mundles are keeping stocks for those people.
Lovely, thank you. If we could go on, is it Tom next? And then we'll have questions at the end of this section.
Okay, thank you very much, Chair. Yeah, I'm Tom Hennessy. I'm the Assistant Director for Integrated Care in Adult Social Care. So I work closely with the CCGs and health partners in order to just explore opportunities for how social care can work better together. And I'm joined for this part by my colleague Anna Makepeace. If you'd like to introduce yourself.
Hi, my name's Anna Makepeace. I'm the Integrated Frailty Manager for Hertfordshire County Council, leading on a lot of the work around care homes and COVID on behalf of the system.
So thanks, Anna. So what I'll do is if I just give an overview as an introduction to section 4 of the report, and then if there's any, perhaps take any questions, and Anna has got the expertise and detail should that be required. So I'm very pleased that we've got a section in this report that's focusing on care staff, because I would consider them to be as much as in the front line of combating this virus as our health colleagues. So you'll see in section 4 that it outlines the arrangements and the experience that we've had in Hertfordshire supporting care settings to comply with a whole range of infection prevention control standards, of which testing staff is a central feature, because we need to accept that the virus isn't generated in the care homes. It's brought in, so testing is absolutely essential that we can identify it and deal with it as quickly as possible. But testing on its own won't do much. It's Jim McManus has this graph that shows the Swiss cheese of all the different types of measures that you need to put in place in order to try to, deal with this virus. But testing is a central one. So it was discussed this morning that we've had to learn how to cope with this and combat this virus as we've gone along. At the end of March, we set up alongside HCPA, health colleagues and public health, a whole range of cells in order to try to closely monitor outbreaks and coordinate our responses. As I said, HCPA were vital in this regard, and they've also operated with HCC a hub to try to manage and coordinate communications with care homes, which has been really valuable. Sharon may well say more about this later. We've worked very closely with Public Health Hertfordshire and Public Health England in order to try and understand how this virus operates. But I think everyone would accept that we're learning a bit more about the virus every week, particularly how it's transmitted and how it seems to be changing and morphing, which is bringing with it constant pressures. It was explained earlier this morning that during phase 1 of the pandemic, it was only staff and residents that were presenting symptoms that were tested. This meant that the virus had the potential to spread undetected, and that was a result in many cases, and it put us on the back foot in terms of trying to respond to the outbreak. However, we learned more, and during the summer we started doing more regular testing with staff and residents. This presented us with the chance to identify where the virus was, who had it, how we could isolate them and respond. But it also then presented a number of challenges around staff having to isolate. And with the inevitable spike in positive results, many of them were asymptomatic and didn't know they had it until they'd had the test. This meant that whilst that was critical for us to be able to respond and support, the pressure it put on the care homes in order to maintain safe staffing levels was really difficult. And we had at least 2 situations where HCC had to coordinate system responses to move residents from a care home into different settings. Anna Makepeace can give any more detail around that because she was very closely involved in both of those. We also discussed earlier a bit around the different types of testing. So we've got the PCR tests, which are more accurate, but involve testing under controlled situations and then going off to a lab for a result. At the back end of December, there were lateral flow testings, which I think, Margaret, you mentioned earlier, which are much more widespread and people can do themselves and only take 20 minutes or so to get a result. But it's not as accurate as the PCR tests and can only really be used as a kind of first phase screening tool. But they are important in terms of trying to get homes to reopen to visitors. And on that point, I'll stop here just around. I appreciate the focus today is on testing staff, which I think has been largely successfully rolled out. It's not without its challenges, but it has been a really excellent piece of work. But I just want to reference the importance of the testing being shared with visitors, particularly carers. And as Roma clearly articulated this morning, this has been one of the most challenging and traumatic experiences that we've had to cope with, in that the carers' role and contribution, not only to see their loved ones, but the contribution that they make to the care homes in order to help support residents shouldn't be underestimated. We are continually waiting guidance and trying to stick with that guidance from central government for us then to understand locally. And there's more detailed guidance that we're waiting that's supposed to be imminent, I think. But it's really important that we support carers and visitors, to re-engage with care homes. I'll stop there, but happy if, Anna, if you wanted to add anything more about the testing regimes, or maybe just to answer the questions.
The only thing I was just going to add, apologies, is that actually one of the things that's really important is also testing in an outbreak. So you can have the regular testing that happens often and has been in place in Hertfordshire since July, but actually one of the real increases and one of the differences in care homes compared to other workplace settings is that we do have more regular testing when they have an outbreak. So from the summer, we've been testing on day 1, but also day 4 to 7. And again, if there's been another case, and I think that's been really important for us in Hertfordshire, because it's allowed us to identify those cases that maybe a few days later we've got a number of asymptomatic staff and residents, but that introduction has given us that flexibility, and that was delivered through our community providers. So the ability to work through Herts Urgent Care, who were the coordinating factor for us, and our 2 community trusts, so Hertfordshire Community Trust and CLCH in Harts Valley in the west of the county, enabled us to deliver a really fast process. And actually through that process, we were able to get results quicker. So one of the real benefits of having it as a local system is when the results were coming back, we weren't relying on the care home to let us know. Actually, the system could let us know, which meant that we could improve our response and offer that support as quickly as possible in order to ensure that home has the right PPE, is supported by staffing, but equally, most importantly, they're isolating those residents and those staff members as quickly as they can to avoid it being spread. I just thought that was something else worth adding in.
Thank you. Ron, you have a question?
Yes, please. I'm not sure. It's actually. I'll try and unpick it very quickly. But PPE sounds simple, but it's actually quite a complex issue. And I'm just trying to unpick it slightly. I've looked at the various pages. First of all, could someone tell us when the PPE that was appropriate to the settings, i.e. the care providers, was available and from whom? So in other words, did the county have to fill in at the start, and has the national portal, when did the national portal catch up? And secondly, there has also been concern about the right type of PPE being used in the proper manner and the necessary training. Could you tell me sort of when the guidance actually caught up with the PPE, that where care providers were getting the supplies of PPE, but when did the instructions, the guidance and the training catch up with the actual issuing of the equipment? Sorry, it's a bit complicated. It's a complicated issue.
That's okay, Ron, and I'll do my best. So so in answer to the first part of your question around where did the stock come from, yeah, in the early stages, so sort of March, April, early May last year, supply was coming either directly from equipment suppliers that care providers were contracting with, or from the central supply that Hertfordshire was building up, and our approach was sort of twofold at that time. It was, in the first instance, to direct providers to request from their own suppliers, but it was also to kind of keep a clear monitor on where they were unable to access that. We were able to allocate from the stockpile that we were building up, if you like, and the national portal went live in May, and I have to say that we were cautious we had low expectations, putting it bluntly, but actually we were pleasantly surprised at how effective that national portal was. So although we weren't able to completely stand down our own access to equipment, because we wanted to assure ourselves that we had an emergency supply, we've actually been very pleasantly surprised that the national portal has been very robust. And one of the things that I wanted to say about that emergency supply and is just to give you a sense of how effective it was. Most of the responses to providers were either fulfilled same day or certainly by next day. So sometimes it was just a case that a provider might have putting in an order from the national portal, but actually the amount that was supplied to them wasn't quite sufficient to take them through a weekend, and we were then stepping in and kind of providing a bit of an emergency supply, for maybe a 48-hour period. So that's the first bit. The second bit about the guidance and when the guidance caught up with the equipment. That's really tricky to answer, simply because, putting it bluntly, it's such a moving picture. It's, if you think about the way that the wider comms from government change, just in terms of general public advice, is it 2 meters social distancing? Is it 1.5 meters? Is it 1 meter plus a mask? Is it so? I don't think it's ever really caught up, just because it's a constantly moving picture. But what I would say is that we probably went through a period of maybe a month in March where there was a real lack of clarity on equipment. But by sort of April, and certainly before the national portal was issuing equipment, Public Health had published national guidance. And what I would say in Hertfordshire is that that gap was minimised by the fact that, I think to our local system's credit, where there was a lack of national guidance or national clarity, actually Jim and colleagues in public health and our colleagues in infection control services within the NHS got round the table, and we made local decisions based on science rather than just making it up as we went along. So I don't think Hertfordshire providers necessarily would have had a gap where there was no guidance. But what I would say is that I think all of the providers, were they here talking to you now, would share the fact that over the course of the year, one of the biggest challenges has been the rapidity of change in that guidance. And I think someone was mentioning earlier the point about using a mask, using one mask for multiple care visits. One of the things that I would say is that initially that was the public health guidance, that actually you could, certain bits of equipment were sessional. Certain bits of equipment were for individual use and should be disposed of straight away. And certainly at one point the national guidance said that for a domiciliary care worker, you could use your mask for more than one call, as long as you didn't touch the mask or remove the mask in between. So once you've touched the mask or removed the mask, it must be disposed of. But actually, if you can keep it in place, jump in your car, go to the next house, then that was okay. That guidance subsequently changed, but for a period of time, that was the national position.
Thanks very much, Tim. Let's. I think that for a tricky subject, there's been quite. I understood that. Thanks very much. Thank you, Leslie.
Thank you. We have a question for Margaret now, please.
Yes. Thank you, Tim. Yes, I was going to really ask. I don't think I've really seen any guidance about level of risk and when you have to use double PPE, and I mentioned triple PPE when I was looking after my mum, because I had COVID and I was the only person who could look after her when the carers wouldn't come in. So I was going to just ask you what the guidance was, and that I did know of a care home in my division, I'm afraid, where the cleaners were not given proper PPE between March and I don't know exactly when, but I suspect it was May when the national provision came in. But I don't know exactly when. I just know that in February and March, there wasn't proper PPE being given to everybody. And obviously, the transmission of the virus wasn't just for carers or cooks, but anybody in a care home. And this was a cleaner in a care home. And sadly, 8 people died in that care home. I think there was such a lot of, such a lot that wasn't known at the beginning. And instead of it being very cautious and all the care homes being told to be very cautious, there was PPE missing right at the very beginning, unfortunately. But I just wonder if you could tell me when the guidance came in and when you wear a visor, because I noticed they weren't wearing visors for their eyes. They were just wearing face masks.
Yeah, as I say, I mean, I would have to go back and provide you with a summary of what guidance was issued when and date. So that's perfectly doable, but it's a constantly moving picture. So the advice and advisors is a really good example, actually, because that's a relatively recent, in the grand scheme of things, a relatively recent addition to things. The point about sort of double and triple PPE, and Tom and Anna may wish or not to comment on this. I think the really tricky thing is that actually we have sadly had some evidence of where overusage of equipment has led to infection, or incorrect usage of items. So unfortunately, the real terror, I think, of this virus is that, you know, it isn't just a case of, well, if one mask is good, then surely two masks must be better. You know, depending on how you're using those and handling them and then disposing of them, you might actually be doubling the vector of transmission. So it is very, very complex, and for that reason, sorry, it's not a coherent kind of here is the date answer for you, but that's why, as our learning has kind of moved on, that guidance has been tweaked and retweaked, and you know, hopefully what I would like to give some assurance of is that that's the one thing that Hertfordshire have been working absolutely flat out with public health and infection control colleagues to make sure that we're keeping ahead of that guidance, and then giving that message back to providers and updating their information and knowledge.
Can I just
Sorry.
And say that any evidence that we have today must be provided on the day. We can't produce something later and then use it as evidence for this topic group. It must be provided at the time. Yeah.
So just coming back on how virulent the Kent variant is now, is PPE being even more strictly applied now because we're living in the Kent variant time?
I'm happy to come in on that. So I think in terms of the Kent variant, I think the current guidance hasn't changed with PPE. So we haven't amended our processes. We've always, throughout the whole of the epidemic, we've worked with all of the care homes and care providers to ensure the correct use of PPE. And Tim is right in terms of some of the homes need additional training, so we put in additional trainings. For example, there's a webinar happening tomorrow which is led by Public Health and our CCG infection control team, which isn't actually around PPE, it's about reminding them the PPE works. A number of our homes and a number of the people that work in homes are very scared, and so actually what they are starting to do is they're starting to over PPE, which is a really bad terminology, but perhaps they're wearing PPE that they haven't been trained to do, which makes it difficult for them to take it off. And so part of that is about really trying to myth bust as much as we can to support them. And actually that's been one of the challenges, is that actually sometimes homes think they're doing the right thing and actually they may not be trained in it. That it just takes one person to potentially to maybe not do something right. So we're working really closely with everybody. So whenever anybody goes into the home, if they notice something that's wrong, if our health professional goes into the home, we encourage them to talk to them about it, then to report us to them, and then we phone the home. So we spend a lot of our time talking around PPE with the homes, trying to ensure that we're keeping on top of it as much as the homes do. I think with the Kent variant, I think the Kent variant led to more cases, so potentially it led to us being more aware, but I would say that our process has been in place the whole time through that. One of the real benefits that has happened is that CQC are now going into Hertfordshire homes, so actually we've been able to support them to go in when we've got a home that's potentially had an outbreak or a home that we have concerns around, and that those eyes on the ground has been essential for us in terms of just trying to understand what is happening. And they will go in when a home is in the middle of an outbreak, which is really important to us. But I wouldn't say our approach to PPE has not changed. We are still waiting for national guidance though, and I think what we do is we are waiting for any national guidance changes, and as soon as it does change, we obviously communicate that and share that, and we'll have a process in place in case any further training is required. My understanding at the moment is there is no change, but obviously it may change tomorrow, in which case we'd respond to that.
And Tina's point earlier about care providers going into homes, she's quite right that if they wear their gloves before they go into a house, of course they're touching door handles. That's actually spoiling what the point of the gloves are, should be inside the house and being protective against the client, you know, so that, or protecting them and protecting the client. So the training of the right use of the gloves applies actually to care providers, domiciliary care providers as well, and carers in homes. I've actually noticed that for myself. One other little thing is really to do with saving the planet.
Margaret, we
plastic.
need to move on really, because John wants to ask a question, and I believe Tom has to go in a minute. And so if there's any questions for him, we need to get them done before he has to leave.
I was just going to say, knowing when to use equipment in certain circumstances, because I think there are times when you can reuse a mask. In fact, you know, we do, because it's my germs that I'm really keeping to myself that the mask is for more than anything else. So, you know, your own personal mask is an issue that, you know, we could be better at not, you know, using as much plastic. But I doubt if that's in your equation at the moment.
Yeah, right. John's question now, please.
Yeah, following on from Anna's comment about training and PPE, actually I want to talk about consistency of testing and whether who actually checks whether the testing is done right or as often as it ought to be in various care homes. Care home A might do it very well, care home B less so. So who is doing the sort of, I don't know, CQC equivalent of checking that these things are being done well?
So we have a weekly call to every home in Hertfordshire. So that's any home, whether it's commissioned or private. So we've had that in place since March through the County Council commissioning team. As part of that conversation, they will talk about testing. So we'll ask the test results, we'll check when the last test was undertaken. And it's quite a regimented process. So we do understand to know when. In terms of when an outbreak, the same conversations, the frequency of the calls increase, but we are aware of that and we're able to pick that up in the conversation. In terms of whether the tests are being undertaken well and whether we're getting the right results, if a test isn't done right, it becomes an inconclusive test, and that would be escalated through to us through the current ways. And then we would talk to the home about whether they need additional support. So do they need training? Is it to do with the fact that some of their residents have very complex needs, so actually do struggle to be tested? And we do have that case in Hertfordshire. So some of our particularly learning disability residents are not able to be tested, and so there's about risk assessments in place with those homes to support what does happen and how they can support them. But it's through those frequent conversations and through those frequent calls that we're able to pick up. And I would say in Hertfordshire, it is probably a handful of cases that I've heard throughout the whole time where homes have maybe not tested when we've asked them to test. In fact, we often have an issue where we've got over testing. So a lot of our residents and staff members are tested a lot. And part of our job is to kind of balance those risks. But in fact, in Hertfordshire, we've had a really good response rate. Whenever the guidance is released, they're happy to change it. The additional funding will make a big difference to them that's coming out now. But we've not struggled really with homes not testing us following the processes. It is homes potentially wanting to do more testing and us trying to talk to them about actually doing more testing may not always be a benefit.
Okay, thank you, Anna.
Okay.
Thank you. Tina, do you have a question now, please?
Thank you. Following on from what you've just said, could you give me an outline of how you're actually checking on the domiciliary carers and their testing? Because again, and anecdotally, I'm hearing that a number who are visiting very vulnerable residents are telling the residents that they're not actually, or they haven't yet had the test.
So it might be better to pass that over to Tim as the home care commissioning rather than myself.
Well, whoever, but
no, that's fine. I'm just trying to look at Tim. Is that okay?
I'm just following on from your original comment.
It's okay.
Yeah, I would welcome being informed of any providers where that is the case. I mean, the way that we keep track of it is that I have monitoring officers in my team who contact all of our contracted care providers at least twice a week. And one of the many lines of questioning that they take in those calls is, have you had access to tests? How many of your staff have been tested? How frequently are they tested? And we also, obviously, from a business continuity point of view, what we want to know is how many of them have tested positive, how many of them are having to isolate from work, so that we can satisfy ourselves that we haven't got workforce issues. So if there are providers where that isn't happening, that's certainly not something that I'm being made aware of at the moment. So which is not to say that at the beginning of the testing process we didn't have issues with providers, you know, because it requires registering with again yet another national portal, and passing on the details and delivery and all of those things. So in the early days there were issues. We did have some care providers that were saying, we haven't had our tests yet, can you follow that up? But I have to say that working with Anna and her team and our colleagues in health, you know, in Hertfordshire, we've done a pretty robust job of plugging those gaps. So if there are still providers where that isn't happening, I would very much welcome any information that can be provided, and we'll follow up on it and make sure that gap is plugged.
It was just a comment that I know at least 2 carers who've given up their work because they haven't been offered the testing. And they're just too frightened to carry on working.
Yeah,
but thank you very much, and I'll contact you out of this meeting.
Thank you, Tina.
Thank you.
Thank you. Now we have a question from Ron.
Thank you. It's a follow-up to Anna's comment on the weekly phone calls, and it occurred to me I'm concerned about the levels of staffing in care homes and in the care providers, and you know that we can cope. And it just occurred to me that with the new system of testing visitors starting next week, or presumably starting next week, have the weekly calls identified any problems of increasing staff to meet that? Because I've understood that some care homes may need 1 or 2 or even 3 extra staff in order just to conduct the testing, which does seem a bit, when we've got a staff shortage, does seem a little bit sort of a problem.
So in terms of that, we're still waiting for the visitor guidance to be released. We believe it will be released today, so we should have more information. We are doing those calls. So we started those calls on Monday morning. So every care home is being called by the monitoring officers so far. So I'm not sure the numbers through, and they're the conversations they are having today and yesterday. So understanding which homes are planning to potentially open for visitors on Monday, which homes are unable because they're in an outbreak. So if your home is in an outbreak, you're not able to open to visitors unless you have an appeal process. So reminding the homes they can appeal as well. That's really important. But also identifying any of those issues. So are we having an issue with equipment? Are we having an issue with staff? And everything's been escalated to me. Currently, nothing has been escalated to me. So as of today, I'm not aware of any staffing challenges. We were aware when the original testing came out in December that there were concerns in care homes around the staffing testing, because it also introduced visitor testing. And obviously the new funding that's being released from the government in the beginning of January is meant to help manage some of this. So at the moment, we're not hearing that. Obviously, we will support the system and keep an eye on the system. I think they probably, as they've been doing the process, they've been lateral flow testing now since December. So it was December when we first rolled out the additional testing for visitors and for staff. I think the processes have improved. I think they've got quicker, but obviously we'll keep a really close eye on it and just understand what is happening in the system. But like I said today, nothing's been escalated around staffing challenges to me.
Thanks, Anna. My worry is, of course, that pound notes are easier to get hold of than staff at the moment, and so therefore having sufficient money to run the system doesn't necessarily mean we can run the system if we haven't got the staff to run it. So, you know, someone further up the ladder should understand that, I hope. Thank you.
think Chris wants to come in with a comment on this now.
I don't know if I'm far enough up the ladder, but that Ron mentioned, but I'm a bit further up the ladder, I suppose. Yeah, Ron, look, you're right. On the staffing, ultimately you've got to get the people in there. Obviously, sadly, some of the homes are running on less occupied beds than they were, so the overall level of occupancy is reduced. That does free up some staffing capacity, if we're being really blunt about it. Clearly, the budget proposals around pay and our emerging position around pay negotiations with the sector will be looking to focus resources on particularly the care home sector because of some of these issues, not just for COVID, but ongoing pay for that workforce we see as a real priority, because you're right, there's a short-term issue here on and a longer-term issue, and the longer-term one we're trying to sort out with what we think will be quite a good pay uplift this year. And of course, just to add on that, Leslie, I forgot to say, of course, the other thing I showed you earlier on that graph around staff is, of course, now we've got 700 less staff in isolation and off ill than we had even 6 weeks ago. So that position's improved by about 700, which is obviously really helpful. And we also know that the schools coming back will help too, because that's obviously presented a number of challenges to different members of staff.
Thanks, Chris. Cheers. Thanks,
Thank you. Can we now? Oh, great. Can we now move on to the Herts Care Providers Association, who will provide an insight on how providers have managed the care of our most vulnerable citizens during the pandemic? I believe it's Sharon Davis.
It is, yeah. Can you hear me all right?
Yes, thank you.
Okay, lovely. So thanks for inviting me today. I've been listening on and off to some of the discussions that have gone on so far. So I hope I'll be able to cover some of the things. Fiona, I think we'll just put that on at the end. I don't think I need that right now. So I'll just chat through a little bit about where we are. So I guess it probably is useful for me to sort of start with a little bit of a background to, as an association, what we do and why we do it and how we work with providers. So we've worked for the past 11 years now. What we try to do is we try to make sure that everything that we do is all about raising quality in care. So any projects that we take on, any work that we do with providers, it's all around that raising of quality. We see ourselves as different to some of the other care associations across the country because our focus isn't on lobbying, which is what many of the other associations is on. It's actually on partnership working. So everything that we've done over the 11 years has been in partnerships, particularly with Herts County Council, but also with the CCGs, public health and other areas. What we do is we listen to providers, we gather that intelligence and we use that for our conversations that we have back and forth. And I hope that, some of the things that you've been talking about today, you'll be able to hear some of the things that we've actually done to ease some of those issues as we've gone through the pandemic. I suppose it is important to just point out, and I was just noticing that the couple of people have been talking about the fact that the council are very close to the providers that have currently got contracts, and some of the things that have been said throughout the day have been about some of the providers that are more private and that don't have contracts with Herts County Council, and so therefore have less oversight. And I guess that as an association, because we work with all of the providers, we are actually able to get to those providers as well. And I think that that's probably been key throughout COVID, in the fact that we've actually been able to make sure that all of our information gets out to absolutely all of the providers rather than just those that are contracted. In terms of the care sector, I think I just wanted to just point out that I think that the fact that the care sector has been a bit of an afterthought sometimes from the government, and that it has been an underfunded sector. And we do believe that some of that has been a contributing factor to some of the issues that we've seen throughout COVID. And I think some of that relates to things like staffing and the fact that staffing wages have not been so good. And so those sorts of things I think that we should take into consideration. What I will say throughout this, all of our providers have actually said to us, the one thing that they find different about working in Hertfordshire is that Hertfordshire County Council can be very swift in the way that they get things out to them. So when we're talking about the funding, that has actually been passed through really, really quickly to providers. Many of the providers that work across different counties have said that that is really important to them, in the fact that Herts County Council have been able to do that, and we've worked with the council to make sure that we've made that process as easy as possible. So looking at the pandemic, I'd say that the key challenges that we've had along the way were PPE, which you've talked about a lot today, and I guess want to just sort of point out from a provider's point of view, we had providers in tears ringing us up at the beginning of the pandemic. They were saying, we want to get PPE, we want to do it right, we don't know what we're doing, how do we do that? So that's why we worked so hard to really, really manage that right at the beginning of the system. And you know, most of those providers out there really do want to do the right thing, and many of the care staff are in the job because they care so much and they want to do it right. However, along the way, so we got over the PPE issue, we then had the testing issues, and then the staffing issues that have come up, and the staffing issues came up because of the testing, so we know that there were linkages with those, and then obviously it's getting the vaccines out to everybody. So all of that has been stuff that we've been working with, and what we did was we provided the provider support hub, which we think has been the key thing that has made the difference throughout the pandemic. It's a place where providers can pick up the phone, send an email, they can get in touch with us and just get an immediate answer. What do I do about this? I'm not sure. Am I supposed to be wearing this PPE? What am I supposed to be doing? All of those sorts of questions will come through the hub, and we're able to manage that. And the way that we manage that is that we have direct links with all of those key partners, and whenever there's a question that we need to find some more information about, we're able to take that information to the person that has the answers and then take it back to the provider. We've supported over 6,000 inquiries through the hub, and I think that, you know, that just shows how providers have been really, really keen to find out the right thing. We talked a bit earlier on about managing discharges, and that has been an area where we've had to support providers. Providers were very concerned at the beginning about having people that were positive coming out of hospital to them, and we were really pleased that the designated centres were set up in the end, and that actually managed that process quite well. I would say that one of the key new partnerships that we've made throughout the pandemic is with public health. So public health have had, and I know that a couple of people have said that earlier on, but public health have been really, really useful in providing us with that information that we need to share with the providers. And we do that by making sure that they have a daily email, and that email has got everything in an executive summary format, so that they've got that information, it's there for them and they can pick that up. One of the things that was just mentioned a little bit earlier was recruitment. So in terms of recruitment, we do have a recruitment service that is funded by Herts County Council called Good Care Service, that links in with the campaign as well. Normally over the year we put about 200 staff through that recruitment service. This year we've done over 550 staff that have actually been brought into the sector, brand new people that wouldn't normally be working in care, and we've helped to support providers where they have had an emergency situation with staff as well through utilising that service. one of the things that I think that we had to learn along the way was about managing clients that actually were feeling isolated. So that was one of our bigger areas. I think the digital inclusion was really helped by the iPads that were given out to care homes. They've been really well used by care homes. There was lots of information around supporting visits, and that's changed along the way, and that's been really difficult for providers, again, because providers are really keen to let people in, but they only want to do that in a safe way. So I think that's been something else for people to think about. I suppose I want to really finish on that. I believe that staff have gone above and beyond throughout the crisis. We've seen that. We've heard from many managers in the pandemic who've been working 70, 80-hour weeks, and then being on call throughout the night time as well, just in case, because they care so much about their staff teams, and they want their clients to be having the best service that they can. So I guess, and if Fiona, we just put that slide up now. I think it's just one slide. I'm not going to bore you with loads of things, but I wanted to just say that we know that we've learned lots of things along the way, and those things that we now need to do is we need to look at how we provide that continued provider support, which has been really good through the different partnerships that we've had. And there are a number of projects there that we're going to do under provider support. We also need to look at resilience, and we need to really look now at how we make sure that our providers continue to be resilient going forward. And then we also need to look at recovery, and we need to make sure that we're not only looking at the recovery of services, but we're looking at the recovery of staff, and we're looking at the recovery of service users as well, who haven't been moving around and haven't been doing the things that they would normally have done. So all those things are on the agenda for next year. So I'm going to stop there and just say, would anybody like to ask any questions?
Jonathan, would you like that?
Okay, Sharon, you we've got a delay. You mentioned that Hertfordshire County Council was quite swift in replying or providing with funds. Do you hear anecdotes from other areas then when perhaps the local authority isn't quite as good?
Absolutely. Some of our providers obviously work across counties. They've got homes in different areas, or they've got home care providers within different areas, and they have found that some of the other areas have one been slow to get it out, but also because they haven't got the good contacts, it's been difficult for them to actually understand what the funds are about, because there are a number of different funding streams that are out there, and it's about trying to sort of get that information into an easy digestible format. And I think that's what our providers have been saying to us, is that, you know, they'd probably say it's never enough. However, what they have had, they've known what they've had to do, and they've got on and they've put their claims in, and they've managed to claim that money. And they do. I mean, the hub has been used big time for finance queries, so that's been really useful. We've worked really closely with the finance team on that.
When you say they haven't got the contacts in some areas, is that the individual named contacts that you're talking about, so they can go to somebody fairly quickly and say, yeah, oh, John, what's going on with this, or whatever?
Absolutely. And I think that, you know, that is something that has been really evident throughout this crisis, is that all of our providers know who their monitoring officers are, they know their commissioners are, they know who they need to speak to. Sometimes they can't get hold of those people, so what they'll do is they'll come to the hub, and then they'll get get the person that way. But actually, I think that is key for people. People want to know a person, and they want to feel like they're supported by that person. So I think there's been, as Anna was saying, there's been lots of phone calls to providers to say, how are you? To the point sometimes where the providers have said, that's enough phone calls, thanks. But very good support from the council and also the CCGs as well. They've provided.
Okay, thanks very much.
Right, thank you. Margaret, next. Would you have a question?
Yes, please, Chair. Thank you. And thank you, Sharon, for your brief overview of HCPA. And I just want to say thank you for existing, because I have heard some very good stories about you, or about your organisation anyway. And I do think Hertfordshire actually do quite well at sort of having an umbrella body. You're not statutory, but you're providing an amazing service, particularly for signposting and being the one point of contact for providers to come to know both guidance and other things that really are need to be coordinated. So I was just going to say, do you provide help for supported living as well as more normal healthcare that we think of? And what is your relationship with Herts Independent Living Service?
Very good is the answer to the second bit. Yes, so we work with all providers, so that is all types of provider, including supported living, and all types of client types as well. So so many of our services are directly for particular client types in terms of the education that we offer. So supported living, yes. However, the one thing that I would say about supported living is that because those services are small, sometimes they find it quite difficult to find the time to actually find out the information. So we might be sending them the information, but actually it's about them actually having that time to sit down and do it. Because if you're a very, very small team, it's always hard to gather that information. But we do support all of those providers, and we do work quite closely with Hills, to the point where we had one provider that was in terrible trouble over Christmas, where they had all their staff suddenly tested positive, and we needed to provide support quickly, and included in that was their chef. So we worked with Hills. Hills quickly came around and said, yep, we can provide the food. We can get into that provider and support that. And they've been there to support whenever we've needed them.
And can I just ask about the private providers? Have you found they've more of them have joined your organisation during COVID?
Yes, yes, that's it. I mean, it's interesting. We've probably got about 4/5 of the market that have always been members, but I think that we're getting there with some of those other providers now. What the one thing that I have noticed is that lots of the bigger providers, so the sort of the multi-site providers that are, your Bupa type providers, they were less likely to be members of ours earlier on. And now all of a sudden, we not only hear from the ones that are in Hertfordshire, but we also hear from the ones that are in other counties as well, wanting to utilise the information that we're giving out, which is fine. It doesn't cost us anything to share that information. But yeah, I mean, it's been good that more of them have been part of the group now. I guess that's been good.
And could I just ask you a little bit about your overview of Hertfordshire to do with inequalities? One of the things is, some places are better than others at digital isolation. The things that really, I suppose, depend on charities, a bit like I was saying about the hospices, that if they're charitable, they don't necessarily have an overview or a computer system to see where their gaps are, to know where there aren't Macmillan nurses, or there isn't a buddy going into a care home with a tablet, or you know, what I've realised is these elderly in isolation often really value somebody going in with their laptop to be able for them to do the Zoom call, and perhaps even teaching them how to do it in the end, and having their own tablet. But that whole side of things, the elderly have been very much digitally isolated, I have the impression. But I just wondered if you had an overview a bit about inequalities across Hertfordshire.
I guess so different providers are able to work differently, and I would say that some of our providers, whether they're homes or even home care agencies, they're very good at making the links with the local community groups that are able to help and support in those ways, which provide that added value. Some of them are really good, and I think that it is often down to the leader in the organisation. So, you know, if you've got a manager who's right on it and actually is able to make those links with the community, then that works really well. And some of them have been able to utilise that throughout COVID. So they've turned some of their services to be online services, and that's been really, really helpful for them. However, some people are not so good at making those connections. So we do a lot of support around leadership, and I personally, as the CEO, I will meet with upwards of 3 providers every single week to actually just sit down with them for an hour or two and talk through all of the different things that there are available in their areas, because it's all very well sending information out, but actually sometimes you need to actually just get in there and talk to people. And you know, Teams has worked. It has worked. It's not as good as face to face, but we've managed to do that. So I think it is. You're right. It's hit or miss. But it's just about giving that information out and growing our leaders. And I think that is really important. Our leaders need to understand about system leadership. They need to understand that actually there's other people that can really, really help them. So the more we can get them into the training rooms and get them to understand that sort of thing, that's really good for them. And hopefully we'll get back to real training one day.
Mm. Thank you.
Thank you. We've got a question from Ron now, please.
Yeah. Hi, Sharon.
Hi, Ron.
Thank you for everything you're doing and your members. Just wondered, you mentioned earlier that the care providers met first with the PPE issue, then testing, then staffing. Sort of as each. Can you give a rough idea of the impression I get? Was that there was first the government announcement, then the government issued guidance, then the council had to make it understandable in partnership with yourselves before it was put out to the care providers. Would that be correct?
It would be correct, but that is a very, very swift process.
Yeah.
I mean, often much of the government guidance for some reason comes out on a Friday night. Don't know why, but actually then what we have to do is we have to translate that, and that's the words I use, because that's what we actually do, is translate that into something that they can easily digest and understand, and put that out, but put it out alongside the guidance. And I will say that our biggest problem along the way has been a press release from the government, followed by nothing. And then you will start to get the questions. Well, what about, as we've talked about the visiting, we know that Monday's the visiting time, but actually they haven't actually given us the guidance yet that we need to go along with that. So that's been a bit of an issue.
I got caught with that the other Monday. I heard on the Today programme about the government had announced visiting from the 8th of March, and I'm supposed to know these things, and so I immediately bothered Chris Badger to find what's going on, and got the up to date. But yes, so to finish off, but what you're saying is that the county have stepped in and has actually resolved those issues fairly quickly, and so that's why we've got we get it sort of quite seamless in a way.
Absolutely. So what will normally happen is I will try to pull out what we need to pull out of it, and then I'll end up phoning somebody like Anna, and Anna will go, well, I'm just going to check with public health and get that right, and then we'll come back and we'll go, but locally, this is what we want you to do.
Lovely.
Or this is where you need to go to get that information.
Yeah. Okay, fine. So in a way, really, your major reliance is on the county, and you know, that hub that's working, and in connection with all the various partners within the county, and it's worked.
Absolutely, and I you know, it obviously there's going to be the odd hiccup along the way that doesn't work so well, but in the main, I would say that the partnership has been so good that it's been the providers that have been saying thank you to us. Which is really good, you know, to hear that they've been saying thank you, and really appreciate. So we held a big network event the other day in January. Got another one coming up in March where Chris and Jim both spoke at that event, and then we had a number of other presentations, and that sort of thing I think just keeps people connected, and that is really important.
Lovely. Thanks, Sharon. Thanks, Leslie.
Thank you.
That's okay. Sharon, can I just ask, how's staff morale through all of this, please?
I would say that on the whole, people literally put their head down, got on with it, and worked really, really hard. And they've worked really hard to a point where now it is becoming that we are starting to see some of the fatigue set in. So where I'm really concerned is I'm concerned from the leadership point of view. So I'm concerned that we'll lose managers because they'll have seen their service through the crisis, and then they'll actually start to say, I just need to go and get an easier job now. So that's a worry for the future. I think that it has, in a way, done us some good in the fact that from a recruitment point of view, more people are hearing or understanding a little bit more about care, and then maybe considering coming and working within the sector. So that's good. But I do believe that our care staff actually are all quite fatigued at the moment, and that, you know, the very fact that we have to keep reminding them now, keep wearing your PPE. I know you've had your vaccination. I know that it feels like the rest of the world is opening up, but you can't. And that's quite a hard message to give to staff that have, you know, really managed well for a long time. And we do have an employee assistance programme that we also run that allows staff to ring into that programme whenever they need to as well. So that is there for them.
Right, lovely, thank you. Can I just ask if we have any members that have any final questions now before we go into our break? So Margaret, have you got your hand up, or is it a legacy hand?
No, this was a quick question just to clarify something Ron was alluding to. At the moment, I think the guidance about visiting care homes is that it was going to be one family member who would be tested and be allowed to visit. Terribly important, and I know Jim McManus has been a fan right from the beginning and has actually tried to, I think, do his own rules in Hertfordshire, frankly. But I was just saying that when that member of the family is indisposed, I really feel quite strongly there should be lateral thinking about, you know, the bubble of that family, or, you know, other people who are related to the person in the care home being allowed to visit, so that the person in the care home doesn't suffer if somebody else is ill. I don't know if I know the guidance hasn't come out yet. It's meant to be on Monday. Have you any clue whether they're going to think like that, to be able to test somebody else so that it's the person in the care home that doesn't suffer?
I'm assuming that there will be some leeway and some exceptions, and most providers will be keen to work in that way with families to try and get those families in if they possibly can. The other thing to remember, I guess, in terms of what we've been telling care providers is please don't let people into your service, because if you let people into your service, you could be letting the COVID in. So you know, providers are wary, and also providers have got insurance issues that they're also wary of as well. They're wary of, if you keep bringing another person and another person and another person, what you're doing is you're opening that up for the rest of the people that also live in that home. So, you know, they have to remember that they're working with a group of people, not just one particular person. So that, I think, is where the dilemmas come. And it is a real dilemma, because I think that on the whole, most care home managers will say to you, we want the families in because we know that the families are providing that much needed additional support for the service users. So they will do the best that they can, but I think that they will also want to manage the safety side of things. I see Chris has got his hand up.
Yeah, I hope it'll be like 4 or something, or some reasonable limited number that they'll be sensible about, that they allow in. But anyway, thank you.
Chris, would you like to come in now?
I mean, just on that, Margaret's point, don't forget the guidance relates to that single visitor is one that can have a full-blown visit, i.e. without a screen or so forth. There will be able to be other visitors behind the screen. So if, say, for one week they said only one visitor can have that really close visit, they'll be quite strong on that because they've got to manage the infection risk. That doesn't stop other visitors going into the kind of arrangements that are currently in place, like, for example, behind the screen or an outdoor visit, which will become easier as we get into the summer. Now, it's not as the same as a close visit, but it's better than not having one at all. So as the guidance currently, as I currently understand the guidance, and hopefully Sharon will nod or shake her head appropriately, the one visitor allocation is one that can have a visit that's a much more personal visit. Now, so if that individual could make it that week, I don't think you'll be able to, if I'm honest, be able to swap in and out, because then you may as well not have a limit. You've just got a rolling program. But they would be able to have other visitors, albeit not as intense, because it'd be behind a screen or outside or something like
that. I was just thinking the risks if you named your 2 family members, for instance, to make sure somebody was there for them, isn't as risky. I mean, you've got people coming in and out of the home, probably service, you know, people who do maintenance and things. As long as they test them, I would have thought that the risks were quite low, as long as you limit who is allowed to visit the person in the home. But it's not up to me, and it's I quite like it to be, but it's I know Jim has been trying to influence government to be more, you know, aware of what it feels like to be somebody with dementia in a care home and how isolated they've been earlier in COVID. So I'm hoping for great stuff on Monday, but we'll see.
Yeah, I think it's just a step in the right direction, Margaret, and it will start to, you know, once they've got more data around vaccine efficacy and so forth, it should. I'm hoping it's one step towards a greater loosening. Clearly, they're in an unreal position in terms of making decisions nationally, because they're in a bit of a no-win situation on it. And they get criticised for no visiting and then criticised for outbreaks and so forth. So it's striking a balance between the two. But what we'll do, as soon as we get the guidance, we'll get that out to care homes, and we'll also organise a webinar for all care homes to, as Sharon says, is a good example, to go through that and make it real for people with a Hertfordshire context. And in the past, we've also written to everyone, Jim McManus, Stretcher Public Health, and myself jointly on it.
Thank you. We've got a question from Jonathan now.
No, I was just going to add to what was just said. I mean, this is not forever, this one-person visit. You know, hopefully it's for a short time, and gradually it'll open out, and you know, normal services may be resumed, or certainly closer to normal anyway. Thanks.
Now we have the opportunity, if you want to question Richard. Anyone wants to ask Richard anything, or anything else to anybody else? No? Oh yeah, Margaret Margaret wants to ask you a question by the look of it.
Yeah, never short of a question.
Yes, Richard, have you heard the whole day so far, or did you come in this afternoon? I didn't. Oh, you're muted. You're muted, Richard.
Muted.
I missed about an hour and a quarter over lunch, but was here all morning, and I've been here since about 2:15.
Did you hear my comment about PCR testing being not reliable on dementia patients, residents?
I did, yes, I did hear that.
Have you had that fed back to you at all? Has anybody else commented on this? Because it's an area that I've been very partly because of my own mother having dementia and being 93, but I'm being tested and then being told if saliva goes on the swab, it's invalidated and it could.
No, that's, to be honest, Margaret, that's not.
When it
I
is.
heard you say that.
Yeah.
But I'm not aware of it, and it's possible that I wouldn't be made aware of it, as it's rather a technical aspect
It's
to
a public health. Yeah.
It is, but I wouldn't be at all surprised that somebody like Anna would have a view on that, who was speaking earlier.
Oh, well, I would. I mean, it was somebody reliable that told me,
Okay.
but it wasn't public knowledge, and it isn't in the guidance when you get a home test, other than they say if it's impossible to do the test in the mouth, and they don't say for whatever reason, they say put it up both nostrils, but then they say this is less accurate than putting it in your mouth. So then, it's not very satisfactory. And so one of the things I have been sort of pushing government to do is to think, and in fact, in the webinar that Jim did last week, I heard, is it Ray Aiden? I've forgotten his name, the guy from Eastern Region, saying lots of different testing is now coming on board. And so that tailor making the test for somebody with dementia, I would say, is, and for special needs, is really important, because they are some of our most vulnerable residents.
Yeah.
And while
so Margaret, I think there's probably a few really important things here, aren't there? One is it's really important that our dementia cared for are vaccinated. That's really, really important. It's also important that, as you've heard this morning, that the rapid lateral flow tests are available, because, as Jim has said, you've heard him say it and so have I, they will pick up the most serious of infections most of the time, and are probably as accurate as a PCR test for those with carrying the most infection, which is really helpful. And of course, somebody could.
Sorry, they're not available at home. So housebound dementia patients, they're not actually available at the moment.
My sense, Chris was mentioned about the amount of testing available, somewhere in the region of 700,000 per day at the moment. It's not beyond the wit of a accessibility, if you like, and visiting and contact to be able to do that now. I don't know the specifics around saliva and intervention, but I'm sure Jim could give you an answer, Mary. Oh, Margaret, sorry.
It's just not been raised actually very much, and
you've raised it. I think either you or your committee can take that further.
Okay, thank you very much, Richard.
Not at all.
I'm grateful. It's
Thank
a
you.
recommendation for the future to get the tests right for the right patients.
Yeah. Okay, I believe Jonathan has a question now, please.
Yeah, it's not so much a question, it's more that, we've been thrown into this pandemic last year so quickly. It surprised us all. And I think that Hertfordshire, when I say Hertfordshire, I mean Hertfordshire County Council, Hearts Care Providers Association, Carers in Heart, and all the organisations have moved and adapted so swiftly to the circumstances that, in a way, it's quite remarkable that we've been able to move so quickly. Because sometimes large organisations find that really, really difficult. But here we've been very flexible, and I think that's to the credit of everybody.
I think there's thank you, Jonathan. I think there's a couple of aspects to this, one of which Chris alluded to earlier, but the planning that started in January that resulted in letters going to care providers in, I think it was the 27th of March. It may have been earlier, but I think that was the date, which set out clearly how we would support the care sector through thick and thin, including how we would support them through the financial restrictions that they were going to face, how we would support them. That has served us well and is still serving us well. So it was that foresight, that thinking, that bringing together the expertise in the round to make sure that there was clarity about what we were doing and why we were doing it. And that has so whether in later months, whether it was infection control, where we were nationally quoted as an example of how to do things, we had set in place already a protocol for how we were going to support the sector. And I suppose, secondly, thinking about moving very quickly, the way that we were able to respond to the shielding programme, which evolved into the sustain programme, whereby we directly supported some 6,000 people a day, and how rapidly the voluntary sector responded to the need that we put out there, in a sense saying, come and help, was just superlative. And I think those are two standout elements of how both ourselves and with our partners we've worked so well. And of course, one of those partners has been HCPA, and as I think as Margaret raised the question about Hills, or Ron, but Hills again stepped up to the plate, delivered more meals, delivered more nutritional packages. Yeah, absolutely, and delivered contact. So yes, I think it's that's it is within. Maybe I would say this, but I've only been the exec member for 2 years, and COVID has actually now been part of my time for longer than non-COVID. What I see is some serious firepower being able to be brought to the problems that come up, and some serious discipline in how to deal with problems and find solutions. And if you think that as well, the management team has, during this time, the management team has been quite shaken up with a change of leadership at the top, with Chris Badger taking over from Ian McBeath and then shuffling around. I am indebted to those that have changed their roles and what they've done, and it's been really positive. Really positive, and I think you hear some of the witnesses today extolling the virtues of some of the joint working that's been able to take place. So, Jonathan, thank you for your question.
I think it bodes well for the future. If we can respond like that in a crisis, then we can respond swiftly when there isn't a crisis. But that's good. Thank you.
Thank you. I believe Natalie has an answer for Margaret.
Yeah, I've been provided with an answer to Margaret's concerns about dementia, and the response we've got is that the PCR swab test needs to take a swab from the area of the throat near the tonsils. It's likely there will be some contamination with saliva, as there is saliva in the mouth normally. This should not normally spoil the test, and that's advice from Public Health.
Thank you. Has anybody else got any more questions before we go for a break? John, is that a legacy hand up?
It is, yeah, sorry, yeah.
Right, okay. Well, should we take our break now and come back at 3:15?
Could I ask for 15 minutes, Leslie, because I need to review the evidence that's been provided to give you a decent summary, if that's okay.
That should be 15 minutes because it's 3 o'clock now. Is that right? 3 o'clock to 3:15.
I've got it nearer to 3 minutes past. So.
Oh right, okay. Well, 20 past 3. Then.
Thank you.
Yeah.
Thank you. That's perfect.
Right. Okay, thank you.
If we actually had a break until, we'd then be back on our time, on our timetable.
you want till 3:30?
I was thinking of Natalie's got a lot to consume, so I thought to give Natalie more time.
I have to go at 4. I'm
quite happy with 15 minutes. So if we said come back at 20 past, then I know members will then be able to help. I'm sure I can.
Okay.
I'm sure I can provide a decent amount there.
Okay, lovely. We'll do 3:20 then. Thank you.
Hello, Chairman. Just to confirm that we're now live again.
Okay, welcome back, everybody. I'd like now to invite our Head of Scrutiny to summarise today's scrutiny for us, please.
Thank you, Chairman. And I think just some general remarks that members heard from a lot of witnesses today, and I think you had a good opportunity to find out the specifics from each of those witnesses and do some of the cross correlation to check out what you were hearing. What I will do is I'll focus in more on the information from this afternoon, and then there are 4 areas, I believe, where there was a kind of gelling of evidence and interest. So in the afternoon, you heard about finances, about you did hear about the complexity, but I think you also heard the efficiency with which that money was then received by the local authority and then distributed quickly to the provider sector, and how that was complemented from resources from HCC, and how there are plans in place to continue to have some funding set aside to for provider needs into the next financial year. What you did hear differently this afternoon was, for instance, the financing of some of the areas that perhaps hadn't been touched on to date, which was end-of-life care and the hospice movement, and quite a lot of eloquent debate took place around the importance of those 2 routes being very well staffed and funded, and the importance that they have for providing support both to the individuals who need that care and also to their carers. But the difficulty is that they're neither fish nor fowl. They fall between social care and health and do a bit of both. And so there was some discussion around that, around how the future funding for both of those streams could be taken forward. You heard a detailed exposition around PPE testing and how the local authority had stepped up to work with the care provider market to provide guidance at the right time, the training to enable people to use the equipment appropriately, how distribution networks were set up quickly and access, and how that quickly segued into the government portal for distributing, and quite a lot of proactive assisting of providers in terms of advice, equipment, training, etc. In terms of contact with providers, you heard around that there are weekly calls to every home since April, and that's not just those homes that are commissioned to provide services. On behalf of ACS, a decision was made to ring all homes because the stability of the market was important to maintain and to understand what issues there were, particularly in a climate where we were facing something unknown of the scale of this pandemic. Moving on, you heard from Sharon Davis of the Hearts Care Providers Association. You heard they've been in existence for 11 years, and their purpose is around raising quality. And I think that was really reassuring for members that it's not a lobbying organisation. You will be receiving lots of comments from your residents about the quality of care provided in a care setting or in individuals' homes, but the focus that HCPA has on ensuring it works with its membership to keep the focus on the quality, and also the focus on partnership working, which was clearly tested during the pandemic. And Sharon articulated that a number of the partners being the county council, the CCGs, public health, etc. So it's a wide-ranging group of partners that it works with, gathers intelligence and shares that intelligence with partners. And I think what you got today, members, was a sense of the system working together, nobody holding on to resources or funding or information or advice. There was a sense that actually this was so dramatic, so pervasive, that actually the system had to work together just to make sure that everybody that was supporting those vulnerable residents. Sharon did articulate, and I think it would come as no surprise that the care sector did come as a bit of an afterthought during pandemic arrangements and has been underfunded for a while, and I think that that's something that members are well aware of. As with other contributors, she talked about the importance of the provider hub, providing that single point of access that providers knew to get where to go to get both personal advice, over the phone, or to raise queries or see what the frequently asked questions was providing them. And then just cantering through to the end, I think Jonathan ended it with what a lot of you had been saying during the day was the agility of the sector, and particularly ACS, to adapt to really challenging circumstances, keep services maintained, work with partners, trying to understand what is best for clients and moving swiftly to do that, and continuing to adapt and modify what the guidance was, what the provision of services was. And particularly against a background where there was a relatively recent executive member appointed, and you'd got changes in the officer leadership as well. And I don't think that's to be underestimated. And I think it's all credit to Ian for passing the baton on as well as he did, but also to Chris and the current team for stepping up to those responsibilities and continuing to provide services in a pretty seamless kind of way. So moving to where all of that takes you as a scrutiny, there seem to be, to my mind, three big areas, and I'm going to just to run through those. Just before I do, I'll just emphasise that clearly this is just the headlines, and if you do decide to shape these into some form of recommendation, they will be supported by an awful lot of the information that I haven't detailed now and won't detail when I go through the areas, but they will be in the report to actually flag up the breadth of evidence that the group has considered before arriving at its recommendations. So my sense is that the comments that have been made, the discussion that's had, is that you would be looking for something which phrases along the lines that the system retains the close working that has been developed and tested and worked really well over the last 12 months, because it's working for the benefit of the users and carers, ultimately that end goal. That there is a possible recommendation around exploring the financing of services to support carers. So that would be, for instance, day services that were mentioned that were closed and putting an extra burden on carers, and hospice and end-of-life care as came out this afternoon. And then I think there's a big area around what you might loosely call system resilience and provider stability. So that would pull in all of the kind of planning for future potential crises points. So that could include perhaps retaining NEVITs and fairways in some way, either to continue to provide that kind of protected setting for people who are at this stage got COVID, but could also provide temporary accommodation should a provider need to close at short notice, either permanently or temporarily. So system resilience and provider stability, because I think you also heard powerfully from Sharon around the fact that care home managers, the leadership, have worked jolly hard throughout this sustained period, and now her concern is, whatever she might be trying to encourage around succession planning, is that managers will be seeking less demanding employment and leave a hole in the market. So just to run through those again: system retains close working for the benefit of users, looks to explore the financing of services to support carers, that there is a recommendation around, or recommendations around, system resilience and provider stability. I've now concluded, Chair, and back over to you and the members for debate and conclusion. Just to say that some of the officers are still in the meeting, so if you did want to test those out with them or talk about timescales or anything, they're available, but they will respond to your questions, Chair.
Mm-hmm. Okay. Have any of you got any questions that you want to ask or any comments? Ron?
Yeah, I've got three things really, I think, and I possibly may drop an email to you and Natalie on them. First of all, I think came clear for me was caring for the carers, and I think that's got to be then that's the informal carers, the family carers. I think that was a key one. Clear guidance. We got a very good steer. Sharon was particularly clear on that if it hadn't been for the good work of our officers from late on a Friday night through the weekend, then clear guidance would not have been available to the sector on the following week. So, because the government guidance needed to be translated, and they were her exact words. So I think that's important and perhaps something picked up. And then finally, looking forward, I think picking out the learning lessons and the variety of services and provisions that were operated by the voluntary sector. There's clearly an issue of sustainability of the voluntary sector there. So I'll leave it at that because let others in, but I'll try and pad these out and let you and Natalie have something. Cheers.
Thank you. Thank you. Tina?
I certainly feel that there ought to be something very strongly put in about well-being, because without the good auspices of all these people that have been involved, who've worked so very hard, we wouldn't have been in the situation that we are. And we have to think about those people's welfare, and we need somehow to put something in place that they recognise that they are cared for. I'll say it no more strongly than that.
Thank you. And Jonathan?
Yeah, thank you. I think Natalie's summary was actually quite comprehensive. I think that the system resilience and looking at NEVITs and fairways and whether it should be used in the way it's been used in the past year, and I think for the foreseeable future that is actually a good idea. I mean, I think the hospice issue is a big one, and I know Margaret raised that earlier on. I don't know whether that is something that is actually too big for us to consider, or for Hertfordshire County Council to consider. Is that more of an NHS government thing when it comes to sort of funding hospices, and whether that's more an area for them than for us? That maybe, I don't know if Chris Badger's got any thoughts on that, but there we are. Thank you.
Thank you. Chris, did you want to come back on that?
Well, on the specific, was that on the specific on the hospice care?
Yes.
Yeah.
I mean, I think we don't commission hospice care as a county council. The clinical commissioning groups do that. I mean, I think hospices have been really heavily involved in the response through the pandemic. I think we could probably look at how we get involved more closely in social care with hospice care and that kind of level. And probably, I've done some work with local hospices in the past, but we could develop more on that. I mean, I wondered perhaps the recommendation might be something along the lines of how we can explore greater integration or further work, building on some of the things that we've done in the pandemic, but other things that we might want to do more of, something like that.
Yeah, well, I mean, Natalie referred to close working, which we already do with lots of organisations. Yeah. Whether we include the hospice movement as well might be a way of doing it.
I think end-of-life care, and particularly, end-of-life care, hospice at home type work is really, really important too. So thinking about that would be, something we could do with local hospices, and I'd be keen to take that forward.
Thanks.
Great, thank you. And Margaret.
Thank you. Well, thank you very much, everybody, for who's contributed, because I think it's been a very worthwhile day. I think there's obviously things that Hertfordshire have done well, like guidance, and particularly Jim McManus and Anna and others interpreting government guidance and making it really useful, making it understandable to actual care providers. And I think that was very well done. And it still will need to be done from Monday, obviously. and also thinking ahead and the fact that we had those two empty care homes, that we were, had closed, but were able to be COVID cleaned and got ready and used as the places for, I've forgotten the word. What's the word? Remember.
Designated settings.
That's the word. Designated care for those with COVID coming out of hospital, and I thought that was it's great that we did that. I think we shouldn't ignore, since we are a scrutiny group, the gaps, and I agree with Ron that I think one of them is thinking about caring for the carers, and I think that's a really good title. I once did a grant application for that at the University of Hertfordshire. I think it's a really important area. It's obviously what Roma was talking a lot about and giving us illustrations that I think are very important for us to be aware of, particularly because they are saving us money. The family carers are saving us a lot of money, because then they're trying to provide for what isn't statutory care, and but they do need looking after. And alongside that are in terms of gaps, are the essential services that are funded by the voluntary sector but have really been hit in COVID. And one of them is the daycare centres that are run by voluntary groups, and community centres that have been run by voluntary sector. And unfortunately, interestingly, when HCPA said they've been providing the information to care providers, I think there has not been as much knowledge about the fact that the county council said they would try to put in some financial support. That was not known, and I know it was not known to this community centre Friendship House in Hatfield. And I just think there are lessons learnt, and that is a gap. And the other is end of life care that is almost exclusively run by the voluntary sector. I mean, I do think the NHS just gets a gift, which they really should be funding better in terms of end-of-life care. And I don't think it should just be the NHS. So whilst Chris says, oh, you don't commission it, there are aspects of bereavement care and counselling, which I do think now we're talking about integrated health and social care. That is a very key area that really should be funded by both, and that unfortunately, because they fall between two stools, effectively being a charity, some of them have gone under during COVID, and that is very serious. So those are that's my summary at the moment, and I hope I would like to make the recommendation that end of life care we do look at, because I'm very well aware that back when I wrote the end of life care report for CQC, the same thing was true, that the NHS and Department of Health were getting end of life care free by very, very committed staff who do it very well. But there are aspects that really aren't able to fund, including their computer systems and seeing the overview and inequalities in health, because they don't have the same computer system to be able to see where the gaps are. And I feel very strongly that that's a whole Cinderella area that really we should think about when we're thinking about care delivery. End of life care delivery is part of that. I think that's what I'll yeah, for the moment. that's my overview of today at the moment.
Thank you. Has anybody else got anything they want to? Right. If that's everything everyone wants to say, as is customary, I'll confirm the wording of the recommendations with the head of scrutiny. Members of the topic group will receive a draft report with comment with a deadline for responses. I'd like to thank members and witnesses for their contribution, and I now declare the topic group's business concluded. Many thanks, everybody.